Welcome back, everybody. David here again with Med School Bootcamp. Thank you for joining us on our musculoskeletal system pathology. So in this chapter, we are now going to talk about non-rheumatologic diseases, and this is going to be contrasted with our next chapter where we'll talk about rheumatologic diseases. So some of the topics we're going to talk about include osteoarthritis, a must know. We're going to compare gout versus CPPD, or sometimes called pseudo-gout. We're going to talk about septic arthritis, achondroplasia, talk about osteoporosis, osteopetrosis, osteomalacia/rickets, osteitis deformans, and finally osteitis fibrosa cystica. So a jam-packed chapter coming up. So if you all are ready, then off we go. So what is osteoarthritis? It's a very common condition. I'm sure somebody you know has osteoarthritis. You've probably heard the term before. But the idea here is that the word osteo is kind of the root word for bone, arthritis is the root word for joint, and itis is kind of the root word for inflammation. So altogether we have bone and joint inflammation. So that is what osteoarthritis is. And osteoarthritis is important because it can present in a variety of different joints, and it's also very, very common. And we're going to talk about it more, but in the pathophysiology here, the general idea is that chronic mechanical stress on the joint can actually lead to this process. And so we'll see that this most commonly affects weight-bearing joints. In particular, if we look at the incidence here, we see the knee is the most commonly affected, followed by the hip and the hand. But you can really get this in any joint, right? People can have osteoarthritis in their spine, they can have it in their shoulder, it can really present anywhere in the body. And what happens is this chronic mechanical stress can potentially lead to decreased proteolycans. And proteolycans are a type of protein that is found in the connective tissue. They provide support to the bones. And what happens here? Well, we decrease our cartilage elasticity. Remember, when we think about bones, we typically have cartilage present on the surface called the articular surface. Cartilage helps kind of provide structural support to the joint and a variety of other things. So cartilage lines joints so that when they're moving around, we don't want to have too much friction. We want them to be able to move freely and pain-free. So the decrease in cartilage elasticity is problematic here. Well, what happens if we remove this cartilage from each end of the bone? Well, ultimately, we're going to decrease these supportive structures between them. The cartilage is worn away, and these are going to rub against each other, and this is going to cause friction, which leads to inflammation and continued degradation of the joint itself. So what's that going to lead to? Well, it's going to lead to decreased joint space, and that should make sense to us, right? If we have bones that have cartilage in between them, when they're rubbing against each other, all is well. But as this cartilage ultimately wears away and disappears, now it's a bone-on-bone reaction. Now we're getting that friction, we're getting that pain, and the decreased joint space can lead to something called subchondral sclerosis. And subchondral sclerosis is thickening of the bone in the joints where they are impacted, right? So if they're continuously rubbing over time, subchondral sclerosis or thickening of that bone can actually develop as well, along with some other findings that we'll talk about shortly. So this is the most common joint disorder, and the incidence increases with age. You'll notice I put that kind of in two places here. It's also considered to be a non-modifiable risk factor. It really is kind of one of the most common things that can lead to osteoarthritis, right? We can't do anything about aging. It's just a process that occurs over time. Sometimes it's a little bit oversimplified and just called a wear and tear or wear of the joint disorder. However, there are a variety of biochemical pathways that actually lead to this disease. We don't really need to know them at this level. So when we think about our modifiable risk factors, things like obesity are going to be a modifiable risk factor, as well as overuse. And the reason that obesity is a modifiable risk factor is we have to think about the physics here. When we have pressure on a joint, that's going to compress them more and more. So if we think about our knee, right? If we have 100 pounds of pressure, we might compress the joint this much. If we have 200 pounds of pressure, we might compress it even more. If we have 300 pounds of pressure, we compress it even more. So as you can see, there is an increased pressure on the joint with increased weight that it has to carry. So the more weight the bones have to carry, the more we're compressing that joint space, the easier it is for the bone-on-bone contact to occur, and that is kind of one of our classic definitions of osteoarthritis. Now, our non-modifiable risk factors, we talked about age, it's kind of the primary one I want you to know, but a history of trauma. If we continuously traumatize the knee, a very classic example is a patient who has a meniscus tear. They have a meniscus tear, they get part of that meniscus removed. Remember, the meniscus or the menisci are cushions that are in the knee, right? If these get damaged and these get removed from the body, that trauma to the knee is going to remove one of our protective measures and can lead to an increased risk of osteoarthritis. We can also see an increased risk with family history, patient anatomy, right, depending on the angles of their knees, as well as sex. So females tend to have this disease occur more often. So we break them up into non-modifiable and modifiable. But when we talk about the presentation here, it doesn't matter what the reason is. The symptoms are going to be pretty similar amongst patients. So the key thing is that patients are going to present with an increased level of pain with activity that is relieved with rest. There's typically going to be asymmetric involvement in terms of it can affect one joint but not the other. So it can affect one knee, not the other knee, one hip, not the other hip. And the morning stiffness is going to last typically less than 30 minutes. The reason that this first portion is so important is because these are in direct contrast with rheumatoid arthritis. Rheumatoid arthritis is a condition we will talk about in the next chapter when we talk about rheumatologic diseases, but it is an inflammatory or an autoimmune condition, and it has distinct findings that are different. So in RA, we typically have symmetric involvement, right? So a patient that has affected both knees or both hands, and also the morning stiffness typically lasts greater than 1 hour. So it's something that can progressively get worse throughout the day. Versus with osteoarthritis, we think about it kind of being like startup stiffness, if you will. We get going in the morning, it hurts when we get out of bed, but as we get moving, okay, things start to improve. Towards the end of the day, things will get worse again because we're wearing them down. But again, that timing is a key differentiating factor from rheumatoid arthritis. Now, we can see some other key characteristics in these patients as well, including crepitus, which is essentially a crunching or a cracking of the joint. I often think about like Rice Krispies, right? You pour the milk in and you hear this crunching and crackling. That's the idea. When we're moving the joint, when we're putting it through motion, we're getting this crepitus sensation, as well as finding a decreased range of motion. As things get progressively worse, it's painful, it's harder for the patients to move that joint, in addition to the buildup of new bone that can actually limit the joint from moving there at all. Now, some very classic findings and a very important image I want you to draw your attention to includes this one over here. They love to ask these types of questions to distinguish patients with osteoarthritis. So there's two different types of joints in the hand. We have the PIP, or the proximal interphalangeal joint, and the DIP, which is the distal interphalangeal joint. And two key findings I'd like you to know about are Heberden nodes, which affect the DIP joint, so we would see right here, and Bouchard nodes, which would affect the PIP joint, or the proximal interphalangeal joint. And a nice memory aid that we can use to remember these names with the joints that they affect is that the H in Heberden node stands for high, which we see affecting this joint right here. And the B in Bouchard node stands for below, which we see affecting this joint right here. So again, these are very classic findings where we essentially see these kind of outpouchings of the joint. So instead of a smooth joint or a smooth finger, right, we see something more like this at the joint itself. This is indicative of osteoarthritis. And again, this outpatching is due to new bone formation, sclerosis, potentially osteophytes. But again, very classic picture that I'd like to show you on the exam. Additionally, a key point I'd like you to know is that osteoarthritis, in contrast to rheumatoid arthritis, is going to affect the distal interphalangeal joint. And so if you see involvement of the distal interphalangeal joint, this makes rheumatoid arthritis less likely. Rheumatoid is more likely to affect the proximal, the MCP, and the wrist itself. We'll talk more about that in the rheumatoid arthritis video itself. Now, moving on to the diagnostics here. So this is mostly a clinical diagnosis, right? A patient's going to present with a variety of findings that you say, yeah, this is most likely to be osteoarthritis. They're going to talk about the pain, the range of motion, some crackling in their joints, and potentially tell you that it's only their left knee that's hurting or that their left knee hurts more than their right knee. Again, consistent with the asymmetric involvement. However, we want to get an x-ray for these patients because you want to make sure there's not other things going on. And this is the first line imaging that you want to get. So what is that x-ray going to show? Well, it's going to show irregular joint space narrowing, which you can appreciate on this image over here by seeing the joints have compressed together. Again, there's not a whole lot of cartilage here. Specifically right here, you can kind of see that bone on bone. It's a classic way to describe the x-rays. Bone on bone is a classic diagnostic tool for thinking about osteoarthritis. Now, you can also see subchondral sclerosis, and sclerosis is, again, thickening of the bone. You can really see it as kind of this white area, right, where the bone is rubbing together. It's starting to create new bone because there's a stress there. So that a subchondral or below the cartilage bone is being formed. You can also see osteophyte formation, which can be these little appendages that hang off the bone. So you can kind of see one right here, maybe a little bit over here as well. Osteophytes are bony outgrowths that are associated with joint degeneration. Again, these are all things that happen once the cartilage has worn out. We get that arthritis and we get the bone-on-bone formation or the bone-on-bone rubbing together. All kinds of new things start to happen, including new bone growth. And finally, the other classic one is subchondral cyst. So again, these are kind of below the cartilage themselves. These kind of open areas are a little bit lighter, right? They're not as dense, hyperdense on x-ray. These are consistent with subchondral cysts. So these are really the classic 4 findings that you will see in osteoarthritis on x-ray. Now, based on this physical exam, right, this patient's history, the x-ray, you could probably make the diagnosis of osteoarthritis. However, if we're trying to consider other things on our differential, right, like septic arthritis, rheumatoid arthritis, potentially gout or pseudo-gout, there are other things that we can do to work up this patient. And one key differentiating step that we can do is to get an arthrocentesis or look at the synovial fluid. And what is this going to show us? Well, this is a non-inflammatory condition. So our white blood cell count is going to be non-inflammatory. It's not going to be elevated. The synovial joint fluid should be normal, right? We'll see that in patients with osteoarthritis, they don't have infection to the joint versus septic arthritis. We're going to see what with a white blood cell count? Yeah, we're going to see it go through the roof, right? that's what a septic and infection is going to be of that joint. But in osteoarthritis, that's not the case here. They have inflammation, they have degenerative damage for other reasons than an infection. So this is really important to know that if you were to look at the arthrocentesis synovial fluid, it would be a non-inflammatory arthritis. However, you do not need this to make the diagnosis, right? If a patient is presenting with very clear and classic osteoarthritis, they don't have any signs of infection, they don't have any signs of rheumatoid arthritis, then you can make the diagnosis of osteoarthritis based on their clinical exam. Now, finally, moving on to the management here, we can break this up into non-pharmacologic and pharmacologic interventions. So we said that obesity or excessive weight is a risk factor for osteoarthritis. So one of the classic treatment options is to actually include weight loss. If we're able to get rid of some pounds, we're able to decrease the amount of force on those joints. This can improve the symptoms overall. We can also include diet and exercise, which again can be useful for weight loss, physical therapy, and activity modification. So physical therapy is really important because one of the ways that we can actually help patients in their symptoms is to strengthen the muscles around the joint, right? So we don't have so much compression. We lose the cartilage, right? The arthritis has developed over time, and now we have the bone on bone. But if we strengthen those muscles, we strengthen the quadriceps, the hamstrings, that can actually provide more support for the joint so that patients do not have as much pain in their day-to-day activity. Activity modification can make sense as well. Again, a lot of patients don't want to do this. They want to go hiking. They want to go skiing. However, it is a thing that we can consider when we're talking about activity selection. If a patient loves to run, well, maybe they could consider doing more cycling or biking. Lower impact on the joints can help improve their symptoms as well. Our pharmacologic interventions are going to include things like topical or oral NSAIDs, acetaminophen, or opioids, but please use those sparingly. Again, they do have addictive properties as well. So NSAIDs are okay. However, there are certain patients that cannot have NSAIDs, such as those with chronic kidney disease, so be mindful of the entire patient's picture. Now, if we're thinking about interventional things, we're thinking about most commonly our intra-articular glucocorticoid injection. This is a steroid injection that can help with inflammation and help relieve some of the patient's symptoms for a period of time. There are also some other things out there like hyaluronic acid injections, PRP, etc., etc. So there are a lot of things we can inject into the joint to try and improve the patient's symptoms overall. Now, if everything fails, all conservative measures, interventional measures have failed, there is a surgery called a total knee arthroplasty that patients can get as well. That is essentially where they cut out parts of the bone, put on titanium caps at the end. And this is important. Why? Because it adds more space to the joint. They can put in a spacer, but also relieves that bone on bone that the patients are experiencing. And why is this such a bad experience? Because it's very painful. Remember, we have nerve fibers in our bones. So when the cartilage goes away and we're bone on bone, that rubbing, that action, that friction is very painful for patients, and so the surgery can help with that as well. So a very classic vignette they will give you for this condition is a 75-year-old patient who presents, and they're talking about having left knee pain that's been going on for 2 to 3 years now. They really love to hike and walk, but as the pain has progressively gotten worse, they've been unable to do these activities as they would like. They say their right knee hurts a little bit, but it's mostly their left knee that's bugging them a bunch. They don't have any fevers. They don't have any other systemic symptoms. You do a physical exam and you notice that they have tenderness to palpation along the joint line. They have decreased range of motion, and they have some kind of crackling or crunching noise as you move that joint itself. You get an x-ray and you notice this finding right here, which is consistent with decreased joint space narrowing. Now, this is most likely to be osteoarthritis in this patient. They've had symptoms going on for a while. They talk about it hurting worse with activity. They don't have any other really systemic signs or symptoms or fevers. Other joints are not bothering them. And so the x-ray and the clinical picture is most likely pointing to osteoarthritis. The question may then ask you about treatment options. You always want to start with the most conservative measures first. It's not to go right into a TKA if the patient has not tried physical therapy or oral medications as well. So just a quick summary of this video. Osteoarthritis is super high yield, very common in patients. It is a disease that results from chronic mechanical stress to the joint, leading to decreased cartilage elasticity, inflammation, and ultimately joint destruction. That leads to our decreased joint space. It's a very common disorder that has both modifiable and non-modifiable risk factors. The biggest non-modifiable risk factor is simply age. When we think about our presentation here, right? Pain with activity, asymmetric involvement, and morning stiffness typically less than 30 minutes. Key differentiating factor from rheumatoid arthritis, which is why we need to know those ones. We also want to think about the classic findings in the hand, including the Heberden nodes in the distal interphalangeal joint and the Bouchard node in the proximal. Again, it's just kind of this general outpouching we see because of the new bone growth that's forming in the hands. Think about our diagnostics here. Mostly a clinical diagnosis, but imaging is going to include an x-ray as well to look for these classic 4 findings of irregular joint space narrowing, subchondral sclerosis, osteophyte formation, and subchondral cyst. Management is going to include non-pharmacological or pharmacological intervention. And then if we need to, we can move down the list into interventional techniques such as steroid injections, and finally, our total knee replacement if nothing else has worked for these patients. Welcome back, everybody. David here again with Med School Bootcamp. In this next video, we're going to talk about gout. Gout is a super high yield, very commonly asked about question on board exams. It's also fairly common in patients as well, so you might see a patient in clinic who has a gout attack. So gout is a type of inflammatory arthropathy that can occur when these crystalline structures can actually deposit in the joint, lead to inflammation and ultimately destruction. The reason it's so important to think about gout, right, on our differential diagnosis, there's a lot of things that cause damage and destruction to the joints. We talked about osteoarthritis. We're also going to talk about rheumatoid arthritis, gout, something called pseudo-gout, septic arthritis. So when somebody comes in with joint problems, pain, inflammation, there's a large amount of things that we need to think about. And so what we need to do is differentiate what are the distinguishing factors between these conditions. How do we diagnose this patient? And so here we're going to talk about how to diagnose gout. So again, thinking about the pathophysiology here, this is due to precipitation of monosodium urate crystals. And these monosodium urate crystals are just a crystallized form of the molecule uric acid. And what happens is these crystals can deposit in the joints or in the tissues themselves, which can lead to inflammation. We call this an inflammatory crystalline arthropathy. Crystals get in, they cause damage to the joints, arthropathy, and there's inflammation involved. So right off the bat, we're contrasting this with osteoarthritis, which is a non-inflammatory destruction of the joint itself. Now, there's two key ways that this can actually occur. We can either have precipitation by increasing uric acid levels in the body, or by decreasing excretion. Again, typically if our kidneys are working appropriately, we're filtering the correct amount of uric acid in the body so we don't get buildup or deposition in the joints. But if we're not filtering it well enough, that can decrease our excretion. Additionally, if we have some other conditions, some risk factors we'll talk about. So in general, being a male is a risk factor for this. It seems to occur in about a 3-to-1 ratio of male to female. Additionally, the diet is going to be an important key here. So increased purine intake. So what kind of foods have purines in them? Well, foods that have purines in them are a lot of red meats, a lot of seafood and fish and stuff. So sometimes we simplify and say high protein diets can actually lead to increased purine intake, and also alcohol, wine and beer. These can be high in purines as well. So elevated purine intake into the body can obviously lead to higher uric acid levels, predisposing the patient to gout. Similarly, somebody who has tumor lysis syndrome, remember what happens there is that cells can actually burst open and the contents can actually leak out. One of those contents can include uric acid. And so that's going to lead to a significantly increased uric acid in the blood that might not be able to be fully excreted by the kidney itself. Now, what if the kidney is not excreting uric acid because it's damaged? So CKD, remember, a variety of things happen in CKD, one of which is that we ultimately get decreased GFR or decreased filtration of substances by the kidneys that are damaged. And so metabolites can build up. Some that we typically would filter, like uric acid, urea, can build up in the body, which leads to elevated levels overall. Additionally, patients can be predisposed from a genetic predisposition. A very classic one they ask you about is Lesch-Nyhan syndrome. Less commonly, they'll ask you about a glycogen storage disease as well. So what's going on in Lesch-Nyhan syndrome? Remember, we have a defect in the HGPRT enzyme, which decreases the conversion of guanine to GMP and hypoxanthine into IMP. And what happens there? Well, downstream, this leads to increase or excess uric acid and increased de novo purine synthesis. So defect in this enzyme can lead to higher uric acid levels in the body. Now, some additional risk factors include a variety of different medications. They love to ask you about these. So the first two include thiazide and loop diuretics. Remember from our thiazide diuretic videos, we use the memory aid hypergluc for hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. And in general, these medications, both thiazide and loop diuretics, actually can alter the secretion of uric acid in the body by affecting the organic anion transporter. And this alteration of this transporter, right, leads to ultimately increased uric acid levels in the body itself. Now, we can also see this by taking aspirin. And so aspirin, particularly at low doses, actually inhibits tubular secretion, so we retain more of that uric acid in the body itself. And finally, niacin, which remember is our B3. And while this mechanism is not fully understood, it's thought that niacin actually has an inhibitory effect on a uric acid enzyme called uricase, which leads to more uric acid in the body. And or potentially it's also affecting the transporters in the kidney itself. Not fully understood, but the idea here is that it's important to know these medications can lead to increased uric acid levels, thus predisposing a patient to gout. Now, if we think about our presentation here, I want you to compare and contrast with some other joint disorders that we're going to talk about. Patients have acute pain, typically monoarticular. This is in comparison to rheumatoid arthritis, in which we expect to see multiple joints affected, but it's consistent with osteoarthritis, in which we also expect to see, typically monoarticular or one joint affected at a time, although not always. Patients are going to classically present with symptoms in the first MTP joint. This is also called podagra. So you can see over here on the image, I'm circling in orange, this inflammation of the big joint itself. That is the MTP joint, the first one because it's attached to the great toe. And this is a very common area where these uric acid crystals can actually hang out and they can cause inflammation to the joint itself. There's not a very good blood supply to these joints, and thus the crystals can go there and deposit, and they're not getting flushed out like they might in some other joints. Now, the symptoms are going to present very similarly to a lot of other joint pathology. So you're going to expect to see decreased range of motion, swelling, warmth, erythema, and tenderness to palpation. Key point to keep in mind here, there is often a precipitating trigger, so increased uric acid levels, trauma, or dehydration. We talked about a variety of different things up here that can cause increased uric acid levels. But think about trauma to the joint. Anything that predisposes it to worsening symptoms, worsening blood flow, or deposition of these crystals can lead to increased risk of gout. And dehydration. If we're well hydrated and we have a lot of fluids, we have regular blood flow, it's harder for those crystals to deposit. But as fluid levels decrease, that concentration of crystals relative to the blood fluid can actually increase. That increased concentration of uric acid, because we're dehydrated, can lead to an increased risk of gout for patients. Now, another key point I want you to remember here is that symptoms may wake the patient at night. So this is fairly unusual. Of course, a lot of things can wake a patient at night, but in a board style question, the classic one that they're going to ask about here, it's not as classically osteoarthritis. It's not as classically rheumatoid. It's very often a gouty attack, right? They get the inflammation, the flare up, the pain. They wake up in the middle of the night and they come to the clinic the next day and say, oh my gosh, I woke up last night. My toe hurt so bad. What's going on? So for a board style question, I want you to kind of associate that joint pain waking somebody up in the middle of the night with gout until proven otherwise. Also important to note that chronic gout, which is different than an acute gouty flare, which we've been talking about, can present with a pretty unique finding called tophi. So tophi can commonly occur in the olecranon, or like right here on the elbow, the ear, or the Achilles. So you draw your attention over here. So tophi are essentially stone-like deposits of monosodium urate crystals in the soft tissue itself, and they can actually be felt as kind of hard structures, particularly in these locations right here. Now, when we think about our diagnostics, gold standard is going to be the arthrocentesis with synovial fluid analysis. The reason this is the gold standard is because it differentiates it from something we're going to talk about in the next video, which is pseudogout or calcium pyrophosphate deposition disease. It can also help differentiate it from septic arthritis. Again, patients can present with joint pain, but there's a long differential of things to consider, and this helps us tease out what is most likely. So the classic finding is going to be needle-shaped crystals, emphasis on the needle, with negative birefringence under polarized light. So we don't need to get into the physics of what polarized light is, but essentially it's a different type of light. Remember, when we look at pathology, there's always different types of stains we can do, right? We can use Gamsa stain, we can do regular gram stains. Same thing with light. We can look at things under different types of light. So the key things I want to point out here, because they're contrasted to CPPD, is the needle-shaped of gout. So these are needle-shaped crystals, and you can see these over here, these long, thin structures. This is in contrast to the next condition we'll talk about, or pseudogout, which are rhomboid-shaped structures. Additionally, we have negative birefringence under polarized light. A lot of times they might mention this in the question stem itself, and this is kind of a dead giveaway. It's fairly pathognomonic at this level that they're talking about gout itself. And so in gout, we have negative birefringence. Again, in contrast to a weakly positive birefringence that we'd see in pseudogout or CPPD, an alternative condition. So birefringence, without getting into the physics of it, it's basically just an optical property that deals with the refractive index of the crystals itself. Again, you're not expected to know how this works, or the angles, or the mathematics, or the equations, or anything like that. You're specifically required to recognize the terminology or the description of what these look like under polarized light. Another key thing they like you to know is that these are yellow under parallel light, which we can see over here, right? We have our needle-shaped crystal that is yellow appearing under the parallel light. In contrast, we have blue appearance of the crystals under perpendicular light. And again, you can see the blue appearing crystals right here. So again, we have three different ways to think about this: perpendicular light, parallel light, or polarized light, and what are the associated findings. If you notice, under the yellow, I highlighted the double L in red along with the parallel light, and that is to remember that the yellow with parallel, right, the two L's go together, or sometimes the memory aid is that the crystals are yellow when they lay low, and yellow when they lay low makes sense because, again, we have a crystal that's laying low, if you will, that is a yellow under polarized light. So just a little memory aid to keep it straight in your mind. Again, this is in contrast, this is the opposite of pseudogout, or CPPD we'll talk about next, where you have the opposite findings, where they are yellow under perpendicular light and blue under parallel light. So again, we really need to differentiate these two pathologies, and this is one of the best ways to do so. Now, we can also expect to see things like elevated uric acid levels, also called hyperuricemia, although it is worth noting that the level may be normal during an acute attack. And the reason I put that in there is because sometimes a tricky question could give you all the classic findings and the signs and the symptoms of gout, and you're like, yes, this is definitely gout, but to throw you off, the lab might show that the uric acid level is actually normal. Well, again, look at the whole picture. If everything's pointing to gout, particularly if you have this arthrocentesis and these findings right here, it's likely to be gout, even if the uric acid level is not elevated at that point in time. Now, when we think about our management here, we're going to be thinking about our acute versus chronic management. So acutely, we're going to do things like NSAIDs. We're going to help with the inflammation, the swelling. We can also do things like colchicine. So colchicine works by inhibiting microtubules, so it decreases the amount of neutrophils that can actually get to the site itself. It decreases the inflammatory reaction overall. And we can also consider doing steroids for these patients to, again, help with their inflammation, their pain, and alleviate their symptoms. Now, if a patient has chronic gout, they have recurrent episodes, they've had it going on for a long time, potentially they have some of these risk factors up here that you can't really remove or you can't really modify. There are medications that we can use to treat this in the long term. And those classic ones are going to be the xanthine oxidase inhibitors, most commonly allopurinol and febuxostat. So how do xanthine oxidase inhibitors help decrease uric acid? Well, remember in our pathway, we have hypoxanthine, which goes to xanthine, and uric acid. This is moved along by the enzyme xanthine oxidase. So a xanthine oxidase inhibitor essentially wipes out these two steps right here. So that's going to lead to decreased uric acid levels because we're not able to proceed through this pathway, right? We don't have the enzyme to turn hypoxanthine into xanthine. We don't have the enzyme to turn xanthine into uric acid. So again, that's how these xanthine oxidase inhibitors actually work to decrease uric acid levels in the body. We can also use something called a uricosuric agent, such as probenecid, which acts to inhibit the reabsorption of uric acid in the proximal convoluted tubule. Again, if we decrease the reabsorption in the body, that's going to help us get rid of more uric acid and decrease the total serum levels, decreasing the chance of gout occurring. Now, a classic vignette for this patient might be a 45-year-old patient presents to the clinic talking about they're waking up in the middle of the night, they just had a bunch of joint pain, particularly in their big toe, and they can barely stand it, they can barely walk. You gather their history. They tell you that they went out to a business meeting last night. They had a nice big steak and 2 glasses of wine, and they're wondering what is going on with their big toe today. And so you decide in a workup for this patient, you're going to get an arthrocentesis. You're going to look at the joint fluid itself, and lo and behold, it comes back with needle-shaped crystals under light microscopy. You associate these needle-shaped crystals with gout. This also fits the patient's history, right? They're waking up in the middle of the night. They have particular pain in the big joint, or the first MTP joint, also known as podagra. And the patient had a triggering event, right? They had high purine intake just the night before. They had a steak and some wine. This is going to predispose them to a gouty attack. So this is a classic way that they can ask about this in a question stem itself. So quickly to review this video, lots going on here, but gout is an inflammatory crystalline arthropathy where monosodium urate crystals, which are simply crystallized forms of uric acid deposited in tissue, cause inflammation, pain, swelling, joint destruction. There's a lot of risk factors that can increase somebody's risk. These are both related to genetic conditions as well as medication use, and classically they'll talk about the increased purine intake. So high protein, steak, seafood, or alcohol intake as well. Presentation here is going to be pain. It's going to classically present in the first MTP joint. This is known as podagra, although not always. It can present in the ankle, it can present in the knee, it can present in a variety of different places. We're going to see decreased range of motion, swelling, warmth, a lot of things we would expect with an inflammatory arthropathy. We can also see in chronic gout something called tophi, which are essentially white deposition of the monosodium urate crystals in the skin or in the soft tissues that we can see on physical exam. Our diagnostics are going to include our arthrocentesis with our synovial fluid analysis. The very classic and high yield finding is the needle-shaped crystals with negative birefringence. This is so high yield because it contrasts with calcium pyrophosphate deposition disease, which will present similarly in the patient, but will have rhomboid-shaped crystals with weakly positive birefringence. When we talk about managing these patients, we're talking about symptom management here with NSAIDs, colchicine, or steroids. In patients who have chronic gout, right, recurrent attacks, or it's been going on for a long time, we can include some other medications that inhibit the xanthine oxidase enzyme or decrease the reabsorption of uric acid in the kidneys. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about something called calcium pyrophosphate deposition disease. Sometimes it's abbreviated as CPPD. The acute form is also sometimes called pseudo-gout as well. So again, when we're thinking about joint pathology, we can think about all the different things that can cause joint pain that a patient can present with. So we've talked about osteoarthritis, we've talked about gout, we're now going to talk about CPPD, we're going to talk about septic arthritis, rheumatoid arthritis. So there's a very big differential when a patient presents with joint pain. One of these is pseudo-gout. Key thing here for test day is to be able to differentiate pseudo-gout from an acute gout attack. And we're going to talk about how to do that here. So the pathophysiology is going to be the precipitation of calcium pyrophosphate dihydrate crystals that deposit in the tissues and lead to an inflammatory crystalline arthropathy. So right off the bat, again, compare and contrast versus gout. What was going on in gout? Well, we had deposition of monosodium urate crystals, which was a crystallized form of uric acid. but here we have calcium pyrophosphate dihydrate crystals instead. Again, we said this can sometimes be called pseudogout, particularly the acute form. This is going to be more common in older patients, and it's often idiopathic. Again, compare and contrast with gout flares. We talked about all the different things that can lead to a gout flare, including elevated purine levels, medications that you can take, genetic predispositions, and things like that. Pseudogout, however, is mostly associated with an increase in age. There are a couple other associations that they might ask you about. These include things like hemochromatosis, hyperparathyroidism, and joint trauma. Now, when we think about the presentation here, again, joint pain presents very similarly amongst different patients. So we have to think about what are the key differences. So you'll recognize some symptoms that we've seen previously on pathologies. So are they going to be acute pain? This is typically monoarticular. This is important, right? Because this is in concordance with things like gout and osteoarthritis, but it's a difference or in comparison with things like rheumatoid arthritis, where you'd expect to see multiple joint involvement. This most commonly affects the knee joint, and it can present again with decreased range of motion, swelling, warmth, erythema, or tenderness to palpation. Some pretty consistent things we've seen in other joint pathologies as well. Now, it's also important to note that this can be an asymptomatic presentation. Patients can have these, right? And if it's a mild form, they might not present with anything. They might not come to you for it. It could be an abnormal finding that you see on a lab, but it's not actually bothersome for the patient. And if it's not bothersome, we typically do not treat it. When we think about working up these patients, we know that the presentation can be very similar to gout. And so we really differentiate ourselves by looking at the diagnostics. And again, the gold standard is going to be the arthrocentesis or synovial fluid analysis. And the reason is because these are the key differentiating factors between gout. And so here, the classic finding that we're going to see is rhomboid-shaped crystals. Remember in the gout video, I said to keep in mind of what the structure was, and that's because they were needle-shaped crystals. But here we have rhomboid-shaped crystals. So that's a key differentiating feature from gout versus pseudogout. Additionally, another key differentiating factor is this is weakly positively birefringent under polarized light. Do you remember what the birefringence was for gout under polarized light? That's right, it was negative. We would also see these crystals as being blue under parallel light and yellow under perpendicular light. Again, this is the opposite of gout. And so if you draw your attention to our diagram over here, you can appreciate these are rhomboid-shaped crystals. Rhomboid shape meaning they look like rhomboids, something like this. You can kind of appreciate it here and here as well. Again, this is in contrast to gout, which is going to be more of the needle-shaped structure like so. Now, it's also important to point that you can get imaging for these patients. What if you think they might have osteoarthritis? Well, you want to get an x-ray. And one of the classic findings you will see here in pseudogout is something called chondrocalcinosis. And chondrocalcinosis is essentially calcification of the cartilage around the joint. Remember, when we talk about bones, right, we typically have cartilage on the ends of each bone. It helps with movement and stabilization, etc. But if that cartilage becomes calcified, you will see some white spots where you would expect to see the cartilage. So typically on x-ray, the bone is going to be white. The cartilage in between should be kind of this black appearance. It's not something that you should see as bright white. If you do see white, that indicates bony formation or chondrocalcinosis. And this is an important x-ray finding as well. Notice things we're not seeing here. We're not seeing joint space narrowing. We're not seeing the osteophyte formation. We're not seeing the things that we might see in osteoarthritis. Again, being able to compare and contrast these pathologies is really important for making the correct diagnosis for your patient. And finally, on labs, we would expect to see normal uric acid levels. Why is this? Well, because this condition, in contrast to gout, is not due to hyperuricemia. It's not due to elevated levels of uric acid, so we would expect those to be normal on serum. When we talk about the management here, we're going to have really similar things to what we would have with gout. We're going to have NSAIDs, we're going to have glucocorticoids, and colchicine, right? We're going to try to decrease the inflammation, decrease the pain that patients are feeling. With colchicine specifically, right, it can actually inhibit microtubules, decrease the white blood cells coming to the area, causing an inflammatory reaction as well. Key point here, though, this is often a self-limiting disease. So not only can it present as an asymptomatic case, it can actually get better on its own as well if we just give it some time. So it really is about symptom management, helping a patient deal with the pain until the symptoms ultimately resolve. Now, patients who have this chronically will benefit from longer-term NSAIDs and colchicine as well. But again, everything is based on a pro to con analysis. So a patient who has kidney disease is not going to do well with NSAIDs, and particularly not long-term NSAIDs. So that would be a contraindication to using anti-inflammatories in these patients. Colchicine as well, although it's useful for patients to treat their symptoms of CPPD, it can actually cause some adverse effects. A very classic one is gastrointestinal symptoms such as diarrhea as well. So again, everything is a pro to con base when we think about treating these patients. So a classic vignette or patient presentation for this condition is going to be something along the lines of a 65-year-old patient presents to the clinic with ongoing left knee pain. The patient says that their knee has been fine overall for the last several years and they're very active. They just seem to have a flare-up, right? It feels warmer to the touch. They notice that there's worse motion with actually moving the joint and they're wondering what's going on. Where you get a physical exam, you notice the pain, the tenderness of palpation, the warmth, the erythema. There are a lot of things on your differential at this point. There are a variety of different inflammatory conditions that can be caused. So how do you differentiate the two? How do we know this isn't gout? How do we know this isn't RA? How do we know this isn't septic arthritis? Well, to do that, one of the key things we can do is to get the arthrocentesis or synovial fluid, and that's what's done. The question stem tells you that synovial fluid comes back showing rhomboid-shaped crystals, which are weakly birefringent on polarized light. And again, this is a key finding, right? Because this differentiates it from gout, which would have needle-shaped crystals. And so we're going to diagnose this patient with calcium pyrophosphate deposition disease based on their physical exam, their history, and specifically the classic finding of rhomboid-shaped crystals on the synovial fluid analysis. So a quick summary for this video. Again, key here is really to differentiate these pathologies, right? Lots of things can cause joint pain, but what's the reason? Because the reason they're having the joint pain dictates what is our treatment options. So here we have calcium pyrophosphate deposition disease. Acutely, this is also known as pseudogout. We have deposition of these crystals in the tissue, which ultimately leads to destruction and inflammation of the joint itself. More common in elderly patients, this is often an idiopathic condition compared to gout, in which there are a lot of predisposing triggers that can lead to elevated uric acid levels for the patient. When we think about our presentation here, again, really similar to a lot of other joint pathologies, pain, decreased range of motion, swelling, tenderness, things like that. That in and of itself does not help us necessarily narrow down the diagnosis. And so what we do is we look at our diagnostics, the gold standard being arthrocentesis, looking at the synovial fluid. Why is that the gold standard? Because there's very distinct findings we see. We see the rhomboid-shaped crystals, the weakly positive birefringence, as well as it being blue under parallel light and yellow under perpendicular light. These are compare and contrast from gout. On x-ray, we can see chondrocalcinosis, which is essentially calcification of the cartilage, right? Typically, the cartilage would be black on x-ray. We shouldn't actually see the cartilage on x-ray. We should see a space between the bones. If you start to see some white spots in the cartilage, that indicates bone is actually being formed in the cartilage. We call this chondrocalcinosis. Now, we talk about management here. We're looking at anti-inflammatories, glucocorticoids, and colchicine. We're really trying to practice symptom management here and help with their pain and their swelling so that hopefully the symptoms resolve over time. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about septic arthritis. So what is septic arthritis? Well, if we just look at the word here, right? Arthritis is referring to inflammation of the joint, and septic is typically thinking of sepsis, which is obviously dealing with an inflammatory response or inflammation. And so taken together, we have an infection that is creating inflammation of the joint itself. And this is a really important pathology for us to understand, right? Because the differential for joint pain, a patient presents with joint pain, is very long. There's a lot of things that can be going on here in that we have a variety of different things such as osteoarthritis, rheumatoid arthritis, gout, CPPD, also called pseudogout, and septic arthritis. There are some other things as well, but these are the common ones I want you to think about at first. So the question is, how do we differentiate these? How do we separate these when a patient presents with that joint pain? How are we going to determine, is it osteoarthritis, is it rheumatoid, or is it septic arthritis? And so if we look at the pathophysiology of septic arthritis, right, it's going to start with an exposure to an infection. It's an infectious arthritis, right? And this can occur due to either hematogenous spread or direct contamination to the bone. And so hematogenous spread refers to bacteria that's actually in the bloodstream or somewhere else in the body. It can be in the lungs and the GI system that actually goes to the bone itself and causes the septic arthritis to occur. Versus direct contamination, where the bacteria itself has actually infected the joint, but it's not coming from a separate area in the body. Now, what's going to happen? Well, if either one of these things occur, we're going to get inflammation of the joint. And again, this makes sense to us, right? Because an infection has occurred. Just like when we get an infection in our body, we get inflammation. If our joint itself gets an infection, it's going to get inflamed as well. So some of the key risk factors we need to know here are going to be underlying joint disease. So people who have rheumatoid arthritis or anything that has chronic joint destruction are going to be at a predisposed risk for this condition because there's already damage to the structures in the joint. If there's damage to the structures, it might make it easier for bacteria to get in, make it have more of an inflammatory process, particularly if it's coupled with an already inflammatory process such as RA, and this can lead people to a higher risk of having this condition. Now, IV drug users are also going to be at a higher risk. And why is this? Well, IV drug users are at a higher risk of developing infection in the body, right? Anytime a needle from the outside world is introduced to the body, it's potentially introducing infection into the body itself. This can then go to the joint, causing septic arthritis. Patients who have a prosthetic joint are going to be at a higher risk, and this is due in part to the fact that we have a foreign object that's actually in the body itself. It's going to be more of a breeding ground for bacteria or other infections to develop. Patients are immunosuppressed, right? Just like patients who get sick more often, they can have infectious reactions more often where the body does not clear them. Diabetes mellitus, again, because of its relationship to being immunosuppressed, as well as advanced age. All of these things kind of build on that immunosuppression picture. So in general, patients who are more likely to get infections in general advanced age, diabetes, immunosuppression are also more likely to have specific joint infections. Now, some common organisms is going to include Staphylococcus aureus. This is the most common one. When in doubt on a test question, if you don't know what bug they're talking about, it's okay to guess Staph aureus. That's one that shows up time and time again. And here it is as the most common infectious bug for septic arthritis. Now, some other ones I might ask you about include the Streptococcus species, as well as Neisseria gonorrhea and Pseudomonas as well. This is not a complete list. There are other bugs that can cause this, but these are the most commonly asked about ones. The key ones are going to be the Staphylococcus aureus, as well as the Neisseria gonorrhea, because we're going to talk about here shortly something called disseminated gonococcal infection, where there's a classic triad that younger patients can get with septic arthritis. So we'll talk about that soon. The two key ones I feel like you have to keep in mind on these types of questions are going to be the Staph aureus, because it's the most common one, as well as the Neisseria gonorrhea. And the reason is because Neisseria gonorrhea can lead to something called disseminated gonococcal infection. So what is that? This is a systemic disease following an STI with the gonorrhea bug. So we just talked about some of the risk factors for septic arthritis, right? We talked about the immunosuppression, the diabetes, and the advanced stage. But what if a younger patient presents? What if a 25-year-old presents and they don't really have these immunosuppressive states? They don't have the advanced stage. Why might they be having this inflammatory reaction? Well, I want you to think about gonorrhea. Gonorrhea is a very common STI in the younger sexually active community, and patients who are exposed to this infection can actually have it go eventually seed their joint, leading to septic arthritis. Now, when we talk about the presentation here, keep in mind that this is typically a monoarticular problem. And this is important, right? Because we want to compare and contrast. Again, when we're going through our differential, we need to say which ones are monoarticular, which ones are inflammatory, what are the arthrocentesis findings, what are any special labs we might see. Remember, we talked about OA is also a very common monoarticular disease. However, in contrast, RA is often a polyarticular disease where multiple joints are affected at once. This is a contrast from our septic arthritis. Important to know this most commonly affects the knee. It can affect any joint technically, but oftentimes in questions they're going to ask you about the knee, could ask you about the shoulder as well. Less commonly, they'll ask about the smaller joints like the wrist or the hand, but keep in mind it can happen in those as well. So what are the findings? What are we going to see here? Well, these patients are going to have decreased range of motion. They're going to have swelling, warmth, erythema, and tenderness to palpation. Why? Because they're infected, right? The joint is painful. There's a bug. There's an inflammatory response in there. So all these things should make sense to us about why a patient would present like this. They can often have a fever due to infection. Again, this is going to have some systemic signs as well. If you have an infection in your body, right? If you have Staph aureus in your bloodstream, it makes sense that you would present with systemic symptoms, fever, maybe chills. If that Staph aureus then seeds your joint, you can now have significant joint pain and swelling and inflammation, and that is consistent with septic arthritis. And recall in our pathophys, we just talked about a specific type of septic arthritis called disseminated gonococcal infection, which is the systemic disease following STI with gonorrhea. And here is the disseminated gonococcal infection classic triad. So we're going to have the polyarthralgias, we're going to have the tenosynovitis, and dermatitis. So polyarthralgias means that multiple joints are affected. And this is in contrast to maybe an older patient who has a Staph aureus, which is more likely to be monoarticular, but the disseminated gonococcal is more likely to have polyarthralgias. Tenosynovitis is referring to inflammation of the synovial sheath, which actually surrounds the tendon itself. And this can actually present in some of the smaller joints, right? The body, the fingers, the toes, the wrists even. And finally, dermatitis is, of course, inflammation or changes to the skin. So these patients can actually present with pustules or maculopapular lesions in addition to their septic arthritis presentation. So key differentiating feature here, this is migratory and asymmetric polyarthralgias. Again, these are going to be key points when we're differentiating, what's the most likely bug for this patient? Is this a 65-year-old with left knee inflammation, joint swelling, fever? Or is this a 25-year-old with left knee and right shoulder inflammation, joint swelling? Well, that's going to change what we think the most likely bug is, the most likely etiology when we think about our common organisms here. Now, moving on to the diagnostic, super important for this condition, as with all arthritis, the gold standard is going to be the arthrocentesis and synovial fluid analysis. Why is that the gold standard? Well, we're going to see purulent synovial fluid with an increased white blood cell count greater than 50,000. Neutrophil dominant. Why neutrophils? Because it's typically a bacterial infection. This is important because remember, we talked about osteoarthritis, and that is a type of non-inflammatory arthritis. So our white blood cell count is going to be normal or definitely on the low side. Then we have our rheumatoid arthritis, which is an inflammatory arthritis. We're going to see slightly elevated white blood cells. We'll see some of these systemic signs and symptoms, but we won't see elevated white blood cells level to the level of septic arthritis. So in rheumatoid, they might be greater than 2,000, maybe 5,000 to 10,000. When we start to see greater than 50,000, that is significantly elevated. That is more consistent with our septic arthritis. Now, key point here that sometimes they will trick students on. They'll give you a classic presentation of a patient who has septic arthritis, and they'll say, what's the best test? What should we get? Oh, by the way, the patient has a lot of erythema and swelling over the knee joint. Well, the key here is that we don't want to aspirate the joint, or we have a contraindication if there's overlying signs of infection. If we see that the skin is infected, right, there's an obvious apparent infection in the joint, you don't want to stick a needle in there, right? You potentially introduce more bacteria, more of the outside world into the joint. So if that's the case, this is a contraindication to doing arthrocentesis. But if the joint looks okay, if there doesn't appear to be an obvious infection, then this would be a very successful test. Now, we're also going to be looking at our blood cultures and our gram stain, right? What bug is going on there? Can we figure out what's growing? Well, let's take a look. And that's important because it can affect our treatment options in the end. And finally, looking at our x-ray. So x-ray is going to show some soft tissue swelling. It's also going to potentially be unremarkable. And this is important to know, right? Because if a patient has knee pain and we get the x-ray, we talked about what we might find on osteoarthritis, right? The subchondral cysts, the osteophyte formation, the joint space narrowing. But a patient with septic arthritis, because it's a different etiology for their pain, might have a normal x-ray. They might not have these findings. This is why the whole clinical picture is super important for working up these patients. This is particularly important in patients who have prosthetic joints. Again, they already have something from the outside world. They have a foreign body in the system. And if these joints get infected, they can be very problematic for the patient. Sometimes they have to get removed, they have to get washed out. There's a lot of things that are going on. And so x-ray is useful potentially for everybody, but it's mandatory for a patient who has a prosthetic joint. And finally, let's wrap up this video with talking about the management here. So again, this is an infection, so it makes sense to us that antibiotics are going to be the primary thing. This is going to be based on the culture and the sensitivity that we got from the gram stain and the blood cultures we received earlier. Antibiotics are going to be tailored to the bug itself. It's a little bit advanced to go into specifics for each bug right here, but just keep in mind a patient who has a joint infection is likely going to need antibiotic coverage. We're also going to consider aspiration as well as drainage of the native joint. This can be both for fluid analysis, but also for symptom management. If a patient has significant swelling, removing some of that fluid can actually improve their symptoms and comfort. And if the patient has a prosthetic joint, we're going to consult orthopedic surgery. Again, PJIs or prosthetic joint infections can be a major problem for a patient. It can require multi-step revision, and so we need to get the surgeons on board to help with management of these patients. So a question stem for this type of pathology could include something along the lines of a 58-year-old patient presents with left knee pain and right wrist pain. They report that they've had the right wrist pain for 5 years. The left knee pain is fairly new, just started about 1 week ago. The patient reports that they've been feeling a little under the weather lately, a little bit of a runny nose, a little bit of a fever, a little bit of night sweats, and they are wondering what should they do. Well, the question stem is presenting a patient with quite a few different complaints here. So we're concerned that this patient is having systemic signs as well as some joint pain. So we need to work this patient up. Well, the question is, does this patient have something that's more consistent with rheumatoid arthritis, or do they have something more consistent with septic arthritis? And the reason that it's so challenging to answer this question is because the patient has the fever, the systemic signs, as well as multiple joint pains. And so what you need to do, assuming there's no signs of infection, is to get an arthrocentesis. So you get an arthrocentesis of the left joint, and the synovial fluid comes back with a white blood cell count of 48,000. So based on this, what do you think the patient most likely has? Well, the patient most likely has septic arthritis based on the synovial fluid analysis. Yes, it's true the patient was presenting with multiple joint pains, and we said septic arthritis is typically monoarticular, but just because the patient also has right wrist pain doesn't mean it's not due to a separate etiology. Because the question stem said the right wrist pain was present for years, this could just be due to osteoarthritis, it could be due to carpal tunnel, but it's not as consistent with the septic arthritis. But the left knee with the synovial fluid that's significantly elevated in combination with the systemic signs of night sweats and fevers is most consistent with septic arthritis. So this patient likely has septic arthritis, will likely need antibiotic coverage as well. So just a quick summary for this video, septic arthritis is an inflammatory arthritis or inflammation to the joint. It's due to an infectious etiology. Two primary causes are going to be hematogenous spread, where bacteria comes from somewhere in the body into the bone itself, or direct contamination to the bone. This can be due to things like trauma or anything that exposes the bone to a bacterial infection. Common organisms, keep in mind, Staph aureus, as well as Neisseria. However, many other things can actually cause this condition as well. When we think about a presentation, we want to think about it typically being monoarticular. We want to think about classic infectious etiology signs: swelling, warmth, erythema, decreased range of motion because of the pain in the joint, as well as a fever due to an infection. Special unique type here, disseminated gonococcal infection, typically more likely to be seen in a younger individual, specifically a sexually active individual who potentially has a gonorrhea STI. They can present with a classic triad of polyarthralgias, tenosynovitis, and dermatitis. Diagnostics, again, the gold standard is going to be the arthrocentesis. Figuring out what this white blood cell count is really important for narrowing down our differential. We can also look at blood cultures and gram stain to specifically figure out what bug is involved, as well as an x-ray for extra information, particularly if a patient has a prosthetic joint. Finally, management is going to include antibiotic coverage for the bug, considering aspiration, and consulting orthopedic surgery if the patient does have a prosthesis because they have a prosthetic joint infection. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about something called achondroplasia. So let's break down the meaning of the word a little bit. So the root word a means not, chondro means cartilage, and plasia means growth. And so altogether we have not or without cartilage growth. And so achondroplasia is a type of genetic inherited condition that affects bone growth. And it affects specifically bone growth that typically results from cartilage starting. And so recall, there's two key types of bone growth. We have endochondral ossification, and then we also have another type called membranous ossification. And so in endochondral ossification, in its simplest form, we basically have a cartilaginous model of bone growth where cartilage is formed by chondrocytes. This is then later turned into woven bone by interactions between osteoblasts and osteoclasts, and ultimately it is remodeled into lamellar bone. Some examples of this include the axial and appendicular skeleton. In contrast, membranous ossification is bone that is formed directly without the use of cartilage. So it's just laid down. That is to say, the woven bone occurs without first having chondrocytes present. It is then again later remodeled to lamellar bone. Some examples of this include facial bones, the clavicle, and the calvarium. Now, so that we set the stage for this, let's talk about the specific pathophysiology with achondroplasia. Well, we have a defect in the FGFR gene. This is the fibroblast growth factor receptor 3. And a key point I want you to know here is that we have increased FGF receptor stimulation. And this increased FGF receptor stimulation leads to decreased chondrocyte proliferation and endochondral ossification, ultimately leading to decreased longitudinal bone growth. The reason this is important is because this is kind of unique. So it's increased activation, or this constitutive activation of the fibroblast growth factor, is actually what inhibits chondrocyte formation. And that is why we get this decrease in chondrocyte proliferation and endochondral ossification. And remember, endochondral ossification is the one that needs the cartilage to actually form. So the cartilaginous bone model growth is going to be affected in patients who have achondroplasia. Now, for the purposes of step 1, I do like you to know this is located on chromosome 4, and it's also important to know that this is a gain of function mutation, which is to say that the mutation in itself is allowing something to happen at an increased rate. That is the increased receptor stimulation, leading to the downstream effects of decreasing chondrocyte proliferation. This is in contrast to a loss of function mutation, where the mutation itself actually stops the process from happening. Now, while there's certainly some inheritance patterns in the chromosome 4 is important to know, this is most commonly going to be a sporadic mutation, although it can be autosomal dominant, and it's important to know that homozygosity is potentially lethal. That is to say, if a patient is autosomal dominant and they get the gene from both parents, it's unlikely this patient would actually survive to be present in the clinic. While patients can survive with one of these genes, two of these genes is likely to cause lethality. Now, achondroplasia is the most common cause of short-limbed dwarfism, and the risk of this actually increases with paternal age. I think this is important to keep in mind, right? Because we often talk about a lot of pathologies that increase with maternal age, the risk of Down syndrome or some other trisomies and various other abnormalities. But this is a unique one in that they're specifically wanting you to know that it's the increased paternal age that can cause a patient's risk to be elevated. Now, when we think about the presentation here, we're really going to be looking at some key classic findings, one of which is disproportionately short stature and size. They have a normal torso, but they have short extremities. This is important to keep in mind, right? Because the primary problem here is with endochondral ossification and the extremities. The appendicular skeleton is going to be the extension of our long bones, our femur, our humerus, legs, and arms. And so it makes sense that these patients are going to have short extremities if they have problem in that growth formation. Now, keep in mind, typically they have a normal sized torso. So it really is the legs and the arm that present the most obvious in the patient on exam. Now, these patients are also going to have craniofacial abnormalities. This can include things like microcephaly, frontal bossing, flattened nose, and a prominent brow. So what are these findings? Macrocephaly is defined as an enlarged head circumference. Frontal bossing and the prominent brows include to increase prominence of these features, both the forehead and the eyebrows, and these patients can also have a flattened nose. Now, one key point that I want you to know for test day that they'd like to ask about is that these patients can have recurrent otitis media, or infections of the middle ear, and this is due to the middle ear deformity. So the bone structures, right, we have little bones inside of our ear. If these bones do not form appropriately, they don't form normally, they're at a higher risk of infection. And so these patients can actually present with recurrent or repeat ear infections, particularly in a younger age, where it might not be as obvious that these patients actually have achondroplasia. In a 3-year-old, it may not be super obvious, right? They're typically short in stature to begin with, but if they're getting these recurrent ear infections, one thing to think about is there a structural abnormality in the ear that predisposes them to more ear infections. And achondroplasia is one of the things that can potentially be on the differential. And finally, it's super important to know that these patients, despite short stature, have a normal lifespan and normal intelligence. They don't have cognitive deficits, right? This is not a brain developmental abnormality. This is purely a bone development abnormality. So keep that in mind on test day as well. When we look at our diagnostics here, not a ton of things to consider, right? There's not really serum labs that you necessarily need, but the main thing to look at is going to be the x-ray, and it's going to show the shortened extremities, which we should also be able to see just visibly by looking at the patient, as well as the forehead prominence, and potentially some scoliosis and spinal canal stenosis is also a fairly common finding in these patients. Now, when we think about the management here, there's not a ton of options for this condition. It's really based on symptom management. So it's mostly supportive things such as physical therapy and helping them in their ability to walk or go about their daily tasks. We can also consider things like early growth hormone therapy. Although this therapy is quite controversial at this time, it doesn't really have great research for increasing bone growth. However, it is something that's kind of under investigation at this time. And you can also consider surgery for significant musculoskeletal deformities. So these include things like scoliosis, spinal stenosis, and genu varum, which is when a patient has bow legs. So instead of coming down at kind of our typical curvature angle, with this being the knee right here, they have a much more pronounced angle with the knee again right here, creating this bow leg appearance. So a classic presentation for this type of condition is going to be something along the lines of a 9-year-old child is brought to the pediatrician by their parent, and the parent is concerned that the child is not as tall as their classmates. They say they've become a little bit worried as the child's growth appears to have been stunted over the last couple years, and they're wondering if there's anything they should do. On a physical exam, you notice that the child is a bit short for his age range, but does not appear to have any cognitive deficits. You note there does appear to be a little bit of frontal bossing, and the patient has a slight curvature to their spine on physical exam. But one thing that should be on our differential here, and potentially what this patient has, is achondroplasia. Classic signs being the frontal bossing, the short stature for their age group, and no cognitive or intellectual deficiencies. So that's one way they can ask about this question. They can also ask some more detailed follow-up questions in terms of the genetic inheritance. What's the chromosome? It's chromosome 4. And they might even ask about what a key association would be, one of which is the recurrent otitis media infections as well. So just to summarize this video real quick, achondroplasia, it is a decrease in our ability to undergo endochondral ossification, so loss of bone formation. This is due to a defect in the FGFR gene, which leads to increased receptor stimulation, ultimately inhibiting chondrocyte proliferation. This is going to be increased with paternal age and present as disproportionately short stature and size. So extremities are short relative to the torso. Head can present as macrocephaly, again, because it's out of proportion to the exam. These patients are going to have a normal lifespan and intelligence level. A lot of this is really going to be based on physical exam and clinical history. You can get an x-ray, which is going to show you similar findings to what you see on the physical exam. You're going to see those shortened extremities, and you might see some spinal conditions as well. When we talk about management here, it really is a supportive thing, right? These patients, again, they have a normal life expectancy, they have a normal intelligence. The defect is purely in their bone formation. So it's going to be about supportive therapies. Some places are considering hormone growth therapy, although again, this is very controversial. And if patients have very severe conditions, we can consider some musculoskeletal surgeries as well. Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about osteoporosis. So think about the word here. Osteo is referring to the word bone, and porosis is referring to the porosity or porousness of that bone. And so what osteoporosis is, it is a porous bone that develops over time due to loss of bone mineral density. And this is important because patients with more porous bone are predisposed to fractures and other complications as well. And so keep in mind, we have osteoporosis, which is different than osteopenia, which is different than osteoarthritis. Osteoarthritis is referring to joints specifically, which are wearing down. We have a separate video on that. Osteopenia is referring to joint softening or decreased bone strength that is less severe than osteoporosis, and osteoporosis is kind of the end stage of that. And we'll talk about the diagnostics, how we differentiate osteopenia versus osteoporosis coming up in this video. So first, when we look at the pathophysiology here, the general overview is that osteoporosis occurs from increased activity of osteoclast relative to osteoblast. Remember, osteoclasts are things that consume bone, and we remember this from the C in osteoclast being consume, and osteoblasts help build bone. And so when we have a discrepancy, right, when we have an increased activity of osteoclasts, that means we're consuming more bone than we're actually building. And this is problematic. Why? Because it increases bone reabsorption, which ultimately leads to a loss of cortical intravecular bone mass. Now, like we said, this loss of bone mass is problematic for the patients because the loss of bone mass is going to predispose patients to fractures and other complications as well. When we think about it, there are two main types that we're going to run into. Type 1 is dealing with postmenopausal osteoporosis. This is kind of the classic presentation. We think about, an elderly woman, it's 70, she doesn't exercise, maybe has low vitamin D levels, and these patients can have osteoporosis.
they can fall and have a hip fracture. That's kind of the classic presentation here. And this is due to a decreased estrogen level as we age. Decreasing estrogen ultimately increases bone reabsorption, which leads to increased weakness and susceptibility to the fractures. So the key here in understanding this pathophysiology is that we have a decreased estrogen level. So at baseline, our estrogen is a hormone that typically stimulates osteoblasts and inhibits osteoclasts. So if we have decrease in this hormone, right, we have decreased estrogen, the opposite effect is going to occur. Now we get less activation of osteoblasts and increased activation of osteoclasts. This is going to lead to bone reabsorption. Again, everything is kind of in balance here, right? We're either tipping it one way or the other. If more osteoblasts are working, we're going to have more bone being built up. If more osteoclasts are working, we're going to have more bone being consumed, more bone being reabsorbed, and an increased risk of osteoporosis. Now, a second type they can ask you about is type 2, which is just basically senile osteoporosis. Similar things here in that we have increased bone reabsorption, increased weakness and susceptibility to fractures, but the reasoning is a little bit different. With senile osteoporosis, it's actually decreased osteoblast activity. So the idea here is that osteoblasts, as we age and get older, they kind of get tired, they weaken out, and so we're not building as much bone. This can predispose to osteoporosis as well. Now, there are a variety of different risk factors they will expect you to know, and some of them should make sense. The first risk factor is going to be in age. This is typically something we see in elderly patients, although not always, as well as being female. Our sex is going to play a role in our likely development of osteoporosis. Again, this has to do with having estrogen hormone and its role in the body. Patients who smoke are going to be at increased risk. Patients who drink, patients who are inactive, have poor nutrition or malabsorption, specifically vitamin D and calcium, are going to be at increased risk. So there's a lot of lifestyle factors that can impact our bone formation and put us at a greater risk of osteoporosis developing. Additionally, these nutritional deficits should make sense to us. We know that bones are made up of a lot of really important molecules, and we know that vitamin D and calcium are really important, right? Drink your milk, the calcium, the strong bones, we've heard of that before. So somebody who is deficient in these molecules, or somebody who has malabsorption, they're not able to actually bring them into the body, will likely have a higher risk of osteoporosis as well. It's also important to know there are some secondary causes of osteoporosis. These include things like corticosteroids, hyperparathyroidism, renal disease, and proton pump inhibitors. This is not all inclusive. There are some other things, but in general, these are the ones they want you to know. So steroids are going to lead to increased bone reabsorption, and this is also going to be what we see in hyperparathyroidism. Remember, the parathyroid glands are going to release PTH, or parathyroid hormone, to stimulate the bones to actually release calcium into the bloodstream. Contrast this with calcitonin, in which calcium from the bloodstream is actually going to go be deposited in the bone. So hyperparathyroidism, an excessive amount of PTH release, is going to lead to more bone reabsorption, leading to an increased risk of osteoporosis. Now, in renal disease, we end up having decreased calcium levels, and this is for a variety of different reasons. We have a whole video on chronic kidney disease that talks about this in more detail, but in general, we are deficient in the enzymes in the kidney, the 1-alpha hydroxylase, that can actually convert regular or inactive vitamin D into its active form, which can work in the body. So that's one problem. Another problem is that we decrease our ability to excrete phosphate from the body. That phosphate has a negative charge, will then bind to the positively charged calcium, and this can contribute to having hypocalcemia in the body. And we talked about previously, low calcium and low vitamin D increase our risk of osteoporosis. And finally, proton pump inhibitors are known to decrease the absorption of calcium and magnesium in the body, which used in the long term can actually increase the risk of osteoporosis for patients. Now, when we talk about the presentation here, some classic findings that we need to be mindful of is first, that this can often be asymptomatic. Patients might actually know that they have osteoporosis. Sometimes the first presentation or the first sign that a patient has osteoporosis is when they come to the hospital with a broken hip. We get some imaging done and we say, oh, this patient had really poor bone quality to put them at a higher risk of having this fracture in the first place. And so patients who have osteoporosis can present asymptomatically, or they'll likely present with one of these fragility fractures. And these are pathologic fractures that occur with regular daily activities. That is to say, a patient is just going about their business. They're just sitting down, they're sneezing, they're bending over, doing regular day-to-day activities. For them to have a fracture from doing one of these basic maneuvers is very unusual. We think about high-impact injuries for fractures. If a patient just sat down and had a fracture in their spine or a vertebral fracture, it's likely that they probably had osteoporosis. It's likely that the bone was not very strong, not very supportive. Otherwise, they would not have had this type of fracture. Now, it's important to know the most common areas this occurs, which include vertebral fractures, femoral neck fractures, and distal radius fractures. This can occur in other places, but these are the most common ones that they're going to test you about on test day, particularly the vertebral fracture. Now, when we think about other signs and symptoms, patients are going to have pain at the site of the fracture and possibly loss of height, particularly with these vertebral fractures. And we're going to talk about this just in a second, but when we get an X-ray, there's some classic findings that we see in vertebral fractures that are going to make sense of this loss of height. So let's go on to it. Let's look at the diagnostics here. Well, patients can get something called a dual X-ray absorptiometry test, also known as a DEXA scan, you've probably heard before. And this is basically an imaging study that is actually used to assess density of the bone by looking at standard deviations in a patient's BMD, or bone mineral density. And it compares the current patient's bone mineral density to a young, healthy patient in the reference population. And so the results of this test is measured by the T-score. And the T-score is just the amount of standard deviations in which the patient's current bone mineral density is different than that of the young, healthy reference populations. And so the classic diagnostic tool of a patient that has osteoporosis is that of a patient with a T-score less than or equal to negative 2.5 standard deviations, and or the patient has a known fragility fracture, which we talked about earlier on. These most commonly occur in the spine, femoral neck, or distal radius. And so a T-score of less than or equal to negative 2.5 standard deviations from a normal healthy patient means that the patient's bone density is way over here on the curve. Remember, if we have a standard bell curve, going this way means we're at positive standard deviations, or we're going towards the top. And if we're going this way, or if we're at negative standard deviations, we're going towards the bottom. So this means this patient, negative 2.5, indicates their bone mineral density is very low compared to a younger healthy adult of the reference population. Now we contrast this with something like osteopenia, which is a T-score between negative 1 to negative 2.4 standard deviations. So osteopenia, like we said at the beginning, is kind of more of a milder form. Like we haven't quite reached osteoporosis, but we're getting bone softening. We're getting signs and symptoms that a patient is going towards osteoporosis most likely. If a patient has a T-score of greater than or equal to negative 1, this is considered normal findings, right? We do expect an elderly patient to have less bone mineral density. It's not necessarily expected that their T-score is 0 or that it's in the positive necessarily, but if it's within 1 standard deviation, that's considered a normal exam for an elderly patient relative to a young, healthy population. So a DEXA scan is really helpful for making a diagnosis of osteoporosis. It's especially helpful in a prophylactic measure, right? We get the scan, we see, does the patient have osteoporosis? Are they at a higher risk? Patients who actually show up with a fracture, right, we're going to need to get an X-ray of just a standard variety, and that's going to show us potentially the fracture, some cortical thinning, and some radiolucency as well. I also want to draw your attention over here to the X-ray. So if you look at this X-ray and you look right here, you can kind of see a normalish, healthy vertebral body. It's got a nice square shape. It's solid in its structure. But if you look just above it, you'll see a bit of a different shape. You'll see a little bit more compression in the anterior portion, and you have more of this wedge-shaped appearance. This is indicative of a classic vertebral fracture for this patient. And again, the reason is patients who have osteoporosis don't have as dense a bone anymore, right? We get a loss of trabecular bone, some cortical thinning that predisposes patients to fractures with daily activities. And so that's what the imaging might look like. And finally, a key thing to know here is going to be the serum labs. So interestingly enough, patients with osteoporosis don't really have serum lab abnormalities. Calcium's normal, phosphate's normal, ALP or alkaline phosphatase is normal, and PTH is typically normal as well. This is really important because the classic way they ask these questions is to give you a patient presentation, and then they'll give you a table with all these different lab values, and they'll ask you which of the following labs corresponds with this patient's presentation. Well, the very unique one that I need you to know is that osteoporosis, despite we think there's going to be serum abnormalities, there's actually typically not. We would expect to see normal serum labs. And we'll talk about some of our upcoming videos, some different conditions in which we will see some differences in calcium, the ALP, and the PTH, or the phosphate as well. So what are we going to do? How are we going to manage these patients? Well, the first thing that we'd like to do is actually encourage prevention, right? If we can slow this bone loss, if we can slow the process of osteoporosis occurring, this is going to lead to decreased risk for a patient actually experiencing one of these fractures. And how do we do this? We can do it for a variety of ways. You can increase physical activity because there's this idea that putting stress on the bones is actually impactful. There's this thing called Wolff's Law where the bones are actually going to remodel to the stress that's put on them. So daily activity like exercising, going for walks, weight training can actually strengthen the bones over time and decrease a patient's risk for developing osteoporosis. Additionally, increasing vitamin D and calcium intake if a patient is deficient can be useful as well because we know a deficiency in these molecules can affect bone health overall. We also want to avoid alcohol, avoid smoking, and glucocorticoids. And this should make sense to us because we talked about up here that these are secondary causes. These are things that can lead to osteoporosis. So if we avoid things that can lead to osteoporosis, we decrease our risk of getting the condition. Now we also have some pharmacological interventions, of which the first line is going to be bisphosphonates. And bisphosphonates are a type of medication that actually work to inhibit the osteoclast in the bone, right? And the problem here is that we have too much activation of the osteoclast. They're consuming too much bone, which is why the bone gets porous in the first place. So giving a medication that slows that process or inhibits the osteoclast can be useful for these patients. However, there are some key adverse effects that we need to know, one of which is jaw osteonecrosis in addition to esophagitis and hypocalcemia. These are really unique findings, particularly the jaw osteonecrosis. Sometimes they'll give you a patient who has a fracture. They'll talk about they're on some unknown medication, and now the patient is having significant pain in their jaw when they're chewing. This could be indicative of jaw osteonecrosis, likely due to bisphosphonate use. Another association with Bisphosphonates are signs of atypical femoral fractures, so basically areas in the femur where we don't expect to see a fracture. So the classic one is a transverse subtrochanteric fracture. This is an area that's not typically fractured in a patient, so if the patient presents with this type of injury, this could be due to bisphosphonate use. Now, we can also consider some alternatives here. These include things like denosumab, which is a monoclonal antibody against the rank L or the rank ligand, and this is going to interfere with the process by which osteoclasts mature and thus decreasing the amount of osteoclasts that are active to consume bone in the body. We also have a medication called teriparatide, which is a PTH analog, which is a very unique finding, right? Because chronic PTH exposure we think is going to lead to more bone reabsorption. However, it's been found that intermittent PTH exposure, which is what we're doing with this medication, can actually increase osteoblast activity and decrease osteoclasts, which is going to lead to more bone formation for the patients. And finally, we have some selective estrogen receptor modulators, including raloxifene. And we talked about previously how estrogen hormone plays a role in preventing osteoporosis. And so a classic board question for osteoporosis might include something along the lines of an 82-year-old woman who comes to the clinic complaining of acute onset back pain that occurred when she was bending over to pick up her phone. She's coming to the clinic again 2 weeks after she was prescribed a medication that would hopefully reduce the incidence of this occurring again. The patient had a DEXA scan, which came back with a negative 2.6 T-score, confirming the diagnosis of osteoporosis. Now you see the patient in clinic after 2 weeks of treatment, and she has some new onset pain in her mandible. The patient states it's tender to palpation and very difficult for her to eat. So the question is, which of the following medications is most likely prescribed? And again, the answer here is going to be bisphosphonates. One, because this is the first line treatment for a patient who has confirmed osteoporosis. So a couple weeks ago, she was diagnosed with it. She was treated with an unknown medication, and now she has signs and symptoms of jaw osteonecrosis. All right, so just a quick summary for this video. Lots of stuff going on here, but osteoporosis is dealing with bone that becomes porous over time. It becomes weakened. Why does it become weakened? Because we have increased activity of osteoclasts relative to osteoblasts, increase in bone reabsorption, and losing our bone mass overall. This is problematic, right? Because this leads to some really key things, such as commonly fragility fractures in patients, particularly elderly patients. It can present in a variety of different ways, but typically it's going to be a patient who has a fracture without an acute trauma, right? They were just doing their daily activities. They bent over to pick something up, they sat down, and they presented with a new onset fracture. Classically, it's going to be a vertebral fracture, and be on the lookout for kind of this wedge-shaped deformity where the anterior portion of the spine actually collapses on itself. Compare that to more of the boxy form of a regular vertebral spine that is not fractured. Now, when we look at the diagnostics here, we can do a DEXA scan, and it's based on our T-scores. The patient have osteoporosis versus osteopenia versus a normal, healthy DEXA scan. Acutely, a fracture is going to need to be worked up with an x-ray finding, and we can also look at serum labs, which we expect to be fairly normal. When we consider our management option here, prevention is going to be first line. We want to increase physical activity, we want to get our diet right, our exercise, increase our vitamin D and calcium intake in a patient who is deficient. But if a patient is needing pharmacologic intervention, the first thing we're going to do is consider our bisphosphonates. Keep in mind, bisphosphonates do have some adverse things that can occur with them, so they should not be prescribed without considering the pros versus the cons. Now, if bisphosphonates cannot be used for whatever reason, or a patient has one of these adverse effects, such as jaw osteonecrosis, we can consider some alternatives, such as our monoclonal antibodies, teriparatide, raloxifene, and rarely calcitonin. Welcome back, everybody. David here again with Med School Boot Camp. So in this video, we're going to talk about osteopetrosis, not to be confused with osteoporosis. So this is another one of our conditions where bone does not form properly. So there's an ongoing balance between activity of osteoblasts and osteoclasts, and those working together in sync is what builds good, strong bone. But there are a variety of conditions like this one where there are various deficiencies in that process and the bone formation is not very good. And so if we draw our attention to the pathophysiology here, this is a genetic mutation that leads to defective osteoclast. Remember, the C in osteoclast reminds us that those are the ones that consume bone versus the B in osteoblast are the ones that build the bone. What happens then is that we get decreased bone resorption, which leads to thick, poorly formed bone and increases the risk of fractures. So again, it's not just that bones are being formed. They have to be formed in a certain way. They have to be formed with this balance. But if this balance is ruined, right, we have defective osteoclasts, we're not consuming the bone, we just have the osteoblasts working to a greater amount, we're building, that doesn't necessarily mean better bone. We don't have the osteoclasts to actually remodel that bone and shape that bone and make it strong. And that's what leads to this thickened, poorly bone, because we have so much activity of osteoblasts with defective osteoclasts, we now have an increased risk of fracture. Again, because there's lots of bone, but it's poorly formed. This condition can present in a variety of different ways. It's typically due to a variety of genetic variations. One of the ones they like to ask about is carbonic anhydrase 2 mutations, which impairs osteoclast's ability to create an acidic environment. So essentially the idea here is that for bone to be reabsorbed, we need to create a lot of acid around those bones, right, to kind of soften it up and help it be reabsorbed into the body. But a defect in this particular enzyme will not allow this process to happen as readily, and this is why osteoclast cannot work. This is not the only way this can present. There's a variety of different genetic mutations, but this is one way that they might potentially ask you about. It's also important to note that this does go by another name, which is marble bone disease. And when we look at these x-rays, this might make more sense to you shortly. So when we think about the presentation here, this is typically going to present in a younger patient with recurrent pathologic fractures. Again, somebody where we wouldn't expect to have a bunch of fractures is having these fractures. Why are they having these fractures? Well, because they have poorly formed bone. It's not that the bone is porous, right? In comparison to osteoporosis, an older person who has porous bone, less density, they might have fractures as well. But in this case, the patient actually has plenty of bone. It's almost too dense. But again, that poorly formed is really the key here in differentiating this pathology. Patients might also present with cranial nerve palsies. This is due to the hyperostosis of the foramina. So essentially, these patients can have increased bone and this thickened bone all throughout the body. It can be in the pelvis, it can be in the spine, but it can also be the small bones inside the head. And these small bones becoming sclerotic and having too much bone formation can actually compress on the cranial nerves. And so a classic way this presents is with a cranial nerve palsy. Additionally, patients can also present with pancytopenia. And the reason for this is due to the overgrowth of cortical bone crowding the bone marrow space. So if we think about our bone, we typically have the thick cortical layer on the outside. And inside the bone, there's the trabecular portion. And in that trabecular portion, or the spongy bone, we have our bone marrow, and a lot of bone cells form. And this is a typical normal healthy bone. But what happens if we have too much growth of that bone? It becomes thick and sclerotic, where you get narrowing of that bone marrow space. And so now the sclerotic bone is kind of compressing, and you see how much smaller our bone marrow space is. Now we might only have this much space for bone cells to actually form. This can lead to the pancytopenia that we're talking about here. This can also lead to extramedullary hematopoiesis. So essentially areas in the body that don't typically form a ton of blood cells start to develop or form those blood cells because of necessity. We need to form the white blood cells, the red blood cells, because we don't have as much bone marrow cavity space as we typically would in a healthy individual. Now, it's also important to note, as with a lot of other things, this can be an asymptomatic presentation. Patients might not show with any symptoms until they start having these pathologic fractures over time. So what are our diagnostics here? Well, the first thing we're going to do is get an x-ray. An x-ray is going to show symmetric, dense osteosclerosis, bone-in-bone appearance. This is also referred to as stone bone. So look over here and see how white this is. We know that on x-ray, bone typically appears white, soft tissue fluid typically appears black. But this is super, super white. This is indicative of a lot of sclerosis, right? This is that stone bone formation that we're talking about. When it's this white, it's this obvious, that means there's too much bone formation going on. If you compare that to bone in a normal x-ray, it wouldn't be this white. It wouldn't be this hyperdense. So if you see this on a finding in combination with a patient's presentation of pathologic fractures, this is likely leading you towards osteopetrosis. Additionally, you can see over here on the spine, very, very white or hyperdense bone formation. Again, indicative of osteopetrosis. Now, for these conditions, it's also important to keep in mind the serum labs, right? We talked about osteoporosis, that a classic question that they will ask you on test day is to give you a variety of different bone conditions and then show you the different serum labs and say which of the following would be affected. Should the calcium be changed, the phosphate, the ALP, or the PTH? And similar to osteoporosis, you can have fairly normal labs in osteopetrosis. One that they might show you is that in severe disease, you can actually get a decrease in serum calcium, but you can also have normal serum calcium as well. So the serum labs in and of itself is not necessarily a great way to tell from osteoporosis because they're similar, but the key thing to tell there is going to be the age difference, right? If it's an 80-year-old patient, I'm thinking osteoporosis. If it's a younger patient, I might be thinking of this genetic inheritance. Additionally, potentially, they could ask you about a special lab that we use, which is that this condition of osteopetrosis is positive for the tartrate-resistant acid phosphatase test. So this could be something that they give you, maybe, maybe not. Keep it in mind. It is important, however, when we compare against other pathologies that we're going to talk about in some other videos, such as Paget's disease or osteitis deformans, where we'd expect to see an increased ALP, contrasted with osteopetrosis and osteoporosis, we would not see that finding. Additionally, in primary hyperparathyroidism, we would see elevated PTH, elevated serum calcium. We're not seeing that here. So again, these labs, these serum labs are really important for differentiating the different types of pathologies when we're thinking about our questions. Now, if we look at our management, there's not a ton of options. This is an inherited condition. You can consider a bone marrow transplant for some forms of this condition. Again, patients have trouble with developing blood cells, and that is why they present with pancytopenia potentially. We can also do things like administering high doses of calcitriol or vitamin D, which may stimulate dormant osteoclasts. Again, why is that helpful? Because the problem here is defective osteoclasts. So anything we can do to help those osteoclasts to consume more bone, because that's the problem here. When they're not consuming bone, we're not remodeling bone, we get the poorly formed bone, leading to fractures. So a classic presentation for this might be something along the lines of a patient presents to the pediatrician. They are bringing in their 9-month-old because they are concerned that they are having an easier time bleeding when they fall and scrape their knee, in addition to the fact they've already had 3 fractures in their short span of life. So one of the things that we can consider here is that this patient might have osteopetrosis. And why is that? Well, think about the clues here, right? Recurrent pathological fractures. Patient having 3 fractures by the age of 9 is typically not normal. So we have to be thinking about, of course, child abuse to make sure that the patient is safe. But if we rule that out, if we're able to determine that's not the reason, they're just falling and continuously breaking their bones, that can be an indication that they have a bone pathology and that they have poorly formed or weak bones. The increased bleeding with some of the scrapes the parents are noticing could be due to the fact that the patient is pancytopenic. So in a younger patient, this might be how it presents. If somebody's a little bit older, let's say it's a teenager, they might present more with the cranial nerve palsies. They might present more with something like hepatosplenomegaly. Why? Because of the extramedullary hematopoiesis. So there's a variety of different ways this can present over time. Typically, it's on the younger side of patients. Not as often will they ask about a 7-year-old patient that has this condition. However, if they do, you need to use the clues that they give you to figure out, is this osteoporosis versus osteopetrosis? One of the great ways to do that is to look at the x-ray, right? If you see this super bright white, that is indicative of sclerotic bone, potentially being osteopetrosis. So just a quick summary of this video here, we were talking about osteopetrosis. This is also known as marble bone disease. Why? Well, because if you look at these x-rays, it's got the stone bone or the marble bone appearance. The pathophysiology is a genetic mutation causing defective osteoclast. So we have decreased bone reabsorption. You might be saying, why is this a problem? Well, because we don't have the balance of osteoblast to osteoclast. So yes, we get a bunch of bone formation, but it's poorly formed, and poorly formed bone is going to increase the risk of fractures. Now, patients can present with pathologic fractures, cranial nerve palsies, pancytopenia, or they can be asymptomatic as well. Maybe that pathologic fracture is their presenting sign to the clinic. When we think about the diagnosis here, we're going to start with imaging. We're going to get an x-ray to look at these findings. And again, we're going to see the hypersclerotic or hyperdense regions on x-ray that are super white shown here. Serum labs are going to be fairly normal. You can start to see some decreased calcium in severe disease. And these patients might also be positive for the TRAP test, or the tartrate-resistant acid phosphatase. Management of these patients, mostly going to be symptom management. We don't have a ton of options here, right? We can do a bone marrow transplant to help with the pancytopenia for various forms of osteopetrosis. And we can also consider giving high doses of vitamin D to hopefully stimulate the dormant osteoclast. Why is this helpful? Because we need those osteoclasts to be active so that we can try to better remodel the bone.
Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we are going to talk about osteomalacia and rickets. And the reason we talk about them together is because osteomalacia is kind of what develops in the adults, and rickets is typically what we see in children. We'll talk about why specifically that is coming up. So if we think about our bones, we can essentially break them up into 3 points. We have the ends, which is known as the epiphysis. We have this kind of middle portion right here, which is known as the metaphysis. And then we have the large shaft region, which is known as the diaphysis. And within the metaphysis, the middle portion, we have something called our growth plates, which is the part of the bone that actually grows during childhood. So as we're getting taller and taller, our extremities are getting longer and longer. It's at that growth plate within the metaphysis that we're actually having these changes occur for the bone to elongate. And this is such an important thing because it brings us to our pathophysiology. And that is that this process is due to a decreased level of vitamin D, which can decrease our overall calcium state and lead to defective osteoid mineralization. However, in children, this can actually impair bone growth at the growth plate itself due to the impaired mineralization. And again, the reason is because in children, the growth plate is still metabolically active, right? It needs that calcium. We need the vitamin D to absorb the calcium to be activated so that bone can elongate. But in adults, these growth plates have actually closed. And so that's why we differentiate osteomalacia versus rickets. So osteomalacia is in adults and rickets is in children. So now, what are some things that can actually cause a patient to have lower levels of vitamin D, which can ultimately decrease the calcium levels leading to this presentation? Well, there's 2 primary categories you need to know: vitamin D dependent things and non-vitamin D dependent things. Far and away, the most commonly tested thing is going to be the vitamin D dependent things, and that's what I've listed here on the slide. So some of those are going to include things like breastfed infants. Babies who are breastfed are not getting enough vitamin D in their nutritional source, and so they can be supplemented with it. But if they're not receiving the vitamin D, this makes sense then that we are going to have decreased calcium overall, because we know there's a strong connection between our vitamin D levels and our calcium levels for a variety of reasons. And within that connection, we can understand that low levels of calcium or low levels of vitamin D leading to low levels of calcium can cause this similar problem or presentation. Now, patients can also have decreased UV exposure. Again, why does this cause problems in our vitamin D? Well, UV exposure is known to convert inactive vitamin D to the active form of vitamin D. And so if we don't have enough of the active form, again, this is going to disrupt our calcium homeostasis and our ability to have good, strong, solid bones. Now, we can also have malabsorption of fat-soluble vitamins. Recall the 4 fat-soluble vitamins are A, D, E, and K. The one we're concerned about here is vitamin D. And so anything that decreases our ability to absorb these fat-soluble vitamins, for instance, celiac disease, we know is a malabsorption disorder,
pancreatitis, patients who have cystic fibrosis. So anything that disrupts the ability to absorb fat-soluble vitamins, particularly vitamin D in this case, can potentially lead to weakened bones, osteomalacia, or rickets for these patients. Now, as I said, I think that the vitamin D-dependent forms of osteomalacia and rickets are the most commonly tested ones, I want you to know, but there are some other things that are considered vitamin D independent things that can actually lead to this presentation as well. Not as commonly tested, so I didn't want to spend time on them here, but these include things like renal tubular acidosis, patients who have chronic low phosphate levels, as well as some types of drugs such as bisphosphonates can affect bone formation and reabsorption. So when we think about the presentation here, how are we going to recognize this in a question stem? Well, patients are classically going to present with bone pain, pathologic fractures, and myopathy. And let's think about this, right? If we have weakened or softened bone because we don't have the vitamin D, we don't have the calcium, we don't have those good strong bones that we want, this can lead us to fractures, and fractures are going to be painful. And so the patient can report that they have bone pain. You can find on physical exam that the bones are actually tender to palpation. In addition, patients can present with myopathy, which are signs of muscle weakness, cramps, maybe even spasms. And this has to do with the fact that these patients can actually show signs and symptoms of calcium deficiency. Remember, some of the classic signs of hypocalcemia are the spasms, the tetany, and the cramping of the muscles. And so that can be a way that these patients present. Now, with children, you're still going to get these pretty classic presentations of bone pain, pathologic fractures, and myopathy, but there's a couple unique things that are specific to children. And the reason that these are specific to children is because they have to do with the growth plate itself. Remember, in adults, we wouldn't expect to see some of these findings because the growth plates have actually fully formed. But in children, you can actually see bony deformities such as genuvarum and kyphosis. And so if you draw your attention over here to this x-ray image, you can see this genuvarum. So in general, our anatomy is basically set up so that we have a little bit of an angle where the femur itself actually meets the tibia and the fibula over here. But in these patients, they get an excessive bend or an excessive angle. And again, this has to do with the fact that they don't have the rock solid bones. They're fairly soft. They're a little bit more malleable, and they can actually create an excessive angle for these patients, which can cause all kinds of problems with their hip and their back and et cetera, et cetera. And again, this is due to the fact that we have a defect in osteoid mineralization. So the bones that are formed are not strong. They're kind of softer. They're a little bit more able to bend in ways that we would not otherwise want them to, or which are not anatomically appropriate for our patient. Now, when we think about the diagnostics here, really, really important is to consider our x-ray findings, which are going to include things like pseudofractures, also called looser zones, and osteopenia. So if you think about it, right, patients who have a defect in the ability to mineralize bone, they're going to have that soft bone, right? And so what can happen with poor osteoid mineralization is you get these areas on x-ray that can actually look like fractures. They are essentially transverse bands of radiolucency, so areas that come together on the bone. They are super radiolucent, which is indicative of defective osteoid mineralization, right? And these can actually look like little fracture lines on x-ray, and that's why they're called pseudofractures or looser zones. Additionally, osteopenia should make sense, right? The problem here is with bone mineralization, so if we can't do this as well, we're going to have softer bone overall. Now, you can also see some other things, particularly in rickets, such as metaphyseal cupping, which is fraying or widened epiphyses, along with rachitic rosaries and craniotabes. And so if you draw your attention up to our x-ray right here, you can see a nice classic finding of the rachitic rosary. You can see these kind of prominent areas along the costochondral junction. And the reason these occur is due to the deficiency in calcium. And the lack of mineralization of the bone can lead to overgrowth of the costochondral junction, which we can then see on x-ray. Now, we can also see the metaphyseal cupping / fraying. So if you draw your attention over here, you can see that the edges of the metaphyses of the bone actually get really wide in these patients, and they can actually flare out. And this is why you call it cupping or flaring, because it kind of looks like a flared appearance or a cup shape. And the fraying refers to the fact that this is not a smooth appearing surface, right? This is kind of a very fuzzy appearing surface, and that's what the fraying is referring to. So the cupping is kind of the shape, and the fraying is referring to the appearance of fuzziness on the x-ray. And craniotabes is simply referring to a softening of the skull bones. And again, this should make sense to us, soft skull bones, because again, the problem overall is that we have defective osteoid mineralization. Now, finally, super important to keep in mind the serum labs. And we're going to have decreased calcium levels, which again should make sense from up here. We're going to have decreased phosphate. We're going to have increased alkaline phosphatase and increased PTH. Why do we have increased PTH? Well, because we have low calcium. Remember, this is the body's way of managing our calcium levels, the balance between PTH and calcitonin. So if calcium is low, more PTH is going to be secreted. And this also explains to us why we have decreased phosphate. Remember, PTH, we talked about previously, stands for phosphate trashing hormone, and we discussed that more in depth in the nephrology section. But if more PTH is released because there's less calcium, we're going to have more phosphate excreted from the body as well if the patient has healthy kidneys. And finally, the elevated ALP is important to know as well. ALP, or alkaline phosphatase, is an enzyme that actually cleaves phosphate groups in alkaline conditions. It's seen in a lot of different tissues within the body, but it's particularly useful as a diagnostic clue for a handful of conditions. So if we think about our differential here, osteomalacia is something that can increase ALP, And another really important thing to have on our differential if we see an elevated ALP is that a Paget disease of the bone, which we will also talk about in this chapter as well. Elevated ALP can also be seen in some types of infiltrative diseases as well as cholestasis also. So keep that in mind. Again, when they're going to give you these presentations and they give you the serum labs, they want you to compare and contrast the different pathologies when we think about our differential diagnosis. So it's really important here to think about what's going on and make sense of these labs and say, do these make sense for osteomalacia? The answer is yes. We know that calcium is a problem. We know the response is going to be elevated PTH, which is going to lead to decreased phosphate. So really the only one that you need to remember for this is the elevated ALP. You need to associate that when we're talking about bone pathology, at least, with osteomalacia/rickets, as well as Paget disease of the bone. Now, finally, what are our management options? Well, we don't have a ton for these patients. Mostly we're going to be supplementing with vitamin D, particularly in breastfed infants, and try to increase their calcium intake overall. There's no real cure for this. We're purely doing a symptom management. We're trying to say, can we help replenish the deficiency that we have? And the deficiency that we have is going to be in the low calcium levels or the low vitamin D levels. And so that's how we're going to try to help these patients with their bone development overall. So how might this present in questions to them? Well, a classic way they could ask this is to say something along the lines of a 6-year-old patient presents to the pediatrician with her parents. For several months, the child has been reporting various bone pains throughout their body without any known trauma or falls to the areas. The parents have also noticed that the child has a little bit of a waddling gait in her walk, and they're wondering if this is normal for her. You decide to work up this patient, get some x-ray findings as well as some labs, and on those labs, you see that there is a low calcium level, an elevated PTH, and an elevated ALP. The question then asks you which of the following diagnoses is most likely for this patient. Well, the most likely thing, based on this presentation of a waddling gait, various bone pains in a child, the lab findings that were discussed, and likely the x-ray findings, if they were to tell you, would discuss things such as the rachitic rosary, potentially the increased angle at the junction of the knee, or some other things such as the metaphyseal cupping and fraying. And all of these are trying to give you clues to the fact that this child likely has rickets. And so it'd be important to counsel the parents on what this entails and what kind of things we can do to help this patient, such as vitamin D supplementation or increase their calcium intake. Now, just a quick summary of this video, osteomalacia and rickets, a lot of similarities. That's why we're talking about them together. We typically consider osteomalacia to be an adult disease, rickets to be a childhood disease. And the real differentiating feature here is the fact that in children, the growth plate has not closed yet versus in adults it has. The problem is with decreased vitamin D, there are vitamin D dependent and non-dependent factors. Most commonly, the ones I want you to know are the decreased vitamin D dependent factors, things such as breastfeeding, low UV exposure, or malabsorption of fat-soluble vitamins. This ultimately leads to defective osteoid mineralization and soft bones. This brings us to our presentation. If we have soft bones, we get predisposed to fractures. This can be painful. This can also show with signs of hypocalcemia, such as myopathy, weakness, things such as that. In children, we have some unique findings of bone deformity. Again, why? Because the growth plates have not closed. As those growth plates are deformed, they can present as a couple different things, such as genuvarum or kyphosis. Diagnostics are really going to be based on our x-ray findings, which we talked about over here. You can see some classic images that they might ask you about or show you a picture of, in addition to our serum labs. Again, building our differential diagnosis. What kind of things will we expect to see an increased ALP in? Well, this, along with Paget disease of the bone, are the two main MSK things we need to know. There are a couple things as well, but it should also make sense to us why our PTH is elevated, why our phosphate is decreased. It's all due to the fact that our calcium is low in these patients. Management options are going to be fairly limited for these patients, but we're really going to try to help build the bone and supplement the best that we can with vitamin D and increase the calcium intake, because these are the things that are deficient in these patients. The reason they get osteomalacia and rickets is because they have the deficiencies. If we help and we catch it early and we're able to supplement these things, we can potentially help alleviate some of their symptoms in the long run. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about something called osteitis deformans, also referred to as Paget disease of the bone. Now, don't confuse this with other types of Paget disease, such as Paget disease of the nipple or Paget disease of the vulva. This is specifically Paget disease of the bone because we are in the MSK section. So what's going on here? Well, think about bone formation. Our bone is constantly being broken down by osteoclasts and rebuilt by osteoblasts. This is a constant process, right? It's in homeostasis where we're building good, strong bone for our daily activities. But anytime this gets disrupted, we can have poorly formed bone, and that's exactly what we see in this particular condition. So if we look at our pathophysiology here, we have increased activity between rank L or rank ligand and the rank receptor. And so if you remember, osteoblasts and osteoclasts work in tandem for bone formation. So osteoclasts themselves have the rank receptor, to which osteoblasts will actually send over the rank ligand to bind to the receptor, and this is what helps them communicate with each other as bone is being formed and remodeled over time. So what happens is this actually leads to increased activity of NF-kappa B, which is a transcription factor that helps regulate various processes in the bone. The biochemical details of it are really not that important for test-taking purposes, but what is important is that we need to know this can lead to increased formation of disorganized osteoclast and osteoblast activity. So what happens there is now we don't have the nice, succinct osteoclast working together. Instead, we have overactivation of these molecules where they're kind of being a little bit chaotic. They're kind of going a little bit crazy. And because of this, this ultimately leads to poor bone formation or woven bone formation. And the idea here is that the increased activity or the chaotic activity of these molecules leads to disorganized bone formation and increased bone turnover. So normal lamellar bone, which is kind of our rock solid, our sturdy bone, is now replaced by poorly formed or woven bone, which is a type of immature, poorly organized bone that is very weak and prone to a lot of problems, including fractures. Now, they also like you to understand the phases that the bones actually go through during this process. And it's broken down into the lytic phase, the mixed lytic and blastic phase, the sclerotic phase, and the quiescent stage. So the first phase is going to be the lytic phase, and that's going to be increased activity of the osteoclast relative to the osteoblast, which leads to increased bone resorption. This makes sense, right? It's called the lytic phase. Think about what lytic means. It actually means that we're having destruction of the bone or softening of the bone. We're eating away at it. The osteoclasts are consuming the bone, but we're not actually building it up. We're not making it stronger. That's the blastic portion of it. So that's the first thing that happens. The second thing is the mixed lytic and blastic phase. And you should be able to make sense of what's going on here, that we have relatively equal amounts of osteoclasts relative to osteoblast activity. So we have an increased rate of bone formation relative to the previous stage. And so now the lytic lesions are actually balanced out with some of the blastic lesions. I think of the B in blastic for building, right? Osteoblasts build bones. Blastic stage is building the bones. Lytic phase is kind of breaking the bones down, making them softer and weaker. Then a third stage is the sclerotic phase. Now we have increased activity of osteoblasts greater than the osteoclast. This leads to increased bone formation. So this is the opposite of stage one. Stage one, we had greater osteoclast activity, leading to greater bone reabsorption. Now we have greater osteoblast activity, leading to greater bone formation, and this should make sense to us. And so again, it's not that these cells are not working at all, right? It's not we have no activity of osteoblast or osteoclast. It's all about relative. It's which one's activating at greater levels at that portion in the cycle. And then eventually we get this continuous accelerated buildup of osteoblast and osteoclast activity that they ultimately essentially wear out. And that's what our final stage is, the quiescent stage or the quiet stage, where we have decreased activity of osteoclast and osteoblast activity overall. And so these are kind of the four primary things that they like you to know to really understand the pathophysiology of this condition. And so you're likely asking yourself, well, what's the problem here? Why does it matter that we have sclerotic phases and lytic phases and mixed phases? The problem is, again, the bone formation is being poorly developed. It's poorly formed bone. It's bad quality. And this can lead to a constellation of findings that we can actually see in a clinical presentation. First and foremost, this typically occurs in adults of older age, and it's often asymptomatic. Patients might not know this is going on, but as it develops over time, as it gets progressively worse, they can develop some things in particular areas of the body, including the skull, vertebral column, the pelvis, and the long bones. And what are those things? Well, we can experience bone pain. Again, poorly formed bone is going to predispose patients to fractures. We talked about this in a previous video when we talked about osteomalacia and rickets. So again, similar to osteomalacia and rickets, anything that makes poorly formed bone predisposes to fractures, predisposes patients to have bone pain. In particular, these types of patients can get something called saber shins, where the tibias, instead of being normally aligned with a slight angle, actually kind of curve out to the side. Now, a very unique finding they love to ask about in question stems is this one right here, the enlarging skull. Patients can present with an increased hat size. Remember, I said one of the classic places this presents is in the skull itself. And so patients who have this disorganized bone can actually create too much of it. It can get thickened, it can take up more space. And in the head, there's not really that much more space to give. Patients don't necessarily notice that their bone is getting thicker and building up in the head itself, but they can have some other external symptoms they present with, such as the increased hat size. Now, think about this bone formation inside the skull itself and all the tiny little foramina that our nerves and our vessels run through. Well, if this bone builds up and it's built poorly and it starts to build up in places it wasn't otherwise building up in, we can get some other unique findings, such as hearing impairments, which can be due to compression of the nerve. And we also previously talked about the pathologic fractures. And so that increased hat size, the hearing disturbances are very classic test questions because they're unusual, right? You think about a neurological symptom, right? Patient can't hear. You're right away jumping to your neurology section of your toolkit of the information that you know. But this is a case where we have a neurological manifestation that's actually related to a musculoskeletal disorder. And that's what makes it such a classic test question. Now, when we think about our diagnostics here, really important to keep in mind that an x-ray is going to show poorly formed bone with areas of osteolytic lesions and sclerosis. Really nice image over here, very classic finding. If you draw your attention to the right pelvis and you compare that to the left pelvis, notice over here it's very smooth, it's very contoured, but over here it looks very sclerotic. It looks like there's maybe some lytic lesions as well. It's very disorganized, the bone formation, and it just doesn't look nearly as clean as the left side. This is very classic of patchy disease of the bone, where you're seeing sclerosis and trabeculations on the x-ray imaging itself. Now, also important to know that we have to keep in mind, what are our serum labs going to look like? Well, we're likely to have normal serum calcium, normal phosphate, normal PTH, but an elevated ALP. This is the classic giveaway that we'll give you on the serum labs. Remember, another condition we talked about that can have elevated ALP includes osteomalacia and rickets. So if they give you the labs in an MSK condition, these are typically the two things that they're talking about. They're trying to point you either to Paget disease of the bone or an osteomalacia/rickets picture. So this is super, super important. I'm actually going to put a star by it because sometimes this is the thing that actually gives the question away. And the reason this is elevated is because ALP is essentially a marker of osteoblastic activity. And we know that in this condition, we're having various time frames at which osteoblasts are overactive. And that's why we can see this elevated level in the serum itself. Now, some other things that can present similar and need to be considered on our differential diagnosis include things like bone metastases, primary hyperparathyroidism, osteopetrosis, or the osteomalacia that we talked about previously. And you have to use the constellation of the patient's presentation, the labs that we can use to differentiate, as well as the imaging findings to distinguish which pathology are they talking about. A less commonly tested diagnostic tool would include things like a urinalysis, which can show increased levels of collagen degradation products, such as hydroxyproline as well. So keep that in mind as a possible presentation. Now, when we talk about the management here, our first line treatment is going to be bisphosphonates. And the reason is because these can actually induce apoptosis or destruction of the osteoclastic cells. We can actually get it to calm down so we don't have so many osteoclasts working in the system itself. Keep in mind, we've talked about previously that bisphosphonates have a bunch of adverse effects, including things like jaw osteonecrosis, esophagitis, and hypocalcemia. Alternatively, if we are not allowed to use these or a patient has one of these adverse effects, we can consider things like calcitonin, vitamin D and calcium, or anti-inflammatories like NSAIDs for pain control. Overall, these are less effective than bisphosphonates, hence they are alternative treatments, but they're things to keep in mind as well on testing. Now, there's a couple unique complications to Paget disease of the bone that I want to mention here. The main one that I want you to know is that of high output cardiac failure. And the reason is because it's fairly unique. These can develop due to the formation of arteriovenous shunts within the bone itself. This can lead to an increased blood flow in the body, requiring the heart to put out more blood faster, ultimately leading to high output cardiac failure. So just to try to put an image to that in really simple terms, right? If we have an arterial supply on one side and a venous supply on one side, right? Blood's going this way, it's coming back to the heart this way. But what happens if a shunt develops? So now that we have a connection between the arterial and the venous system, well, this can create high output cardiac failure because if we think back to our basic physics, right, this decreases the resistance of the system. Typically, blood has to go this way and go back this way. However, now blood has an opportunity to go this way or this way. And the reason it can go either way is because there's a shunt that is developed. This is decreasing the resistance in the heart. So to do this, the heart has to actually pump out more blood, which leads to increased overall blood flow to the system. Over time, this can result in a high output cardiac failure. And finally, the last association they really like you to know is a relation with osteosarcoma. While this is rare, it is a known association that patients who have a long history of Paget disease of the bone can ultimately develop osteosarcoma in that bone. So a classic way they might ask this question includes something along the lines of a 62-year-old male presents to the primary care doctor. He reports that he's had trouble hearing his wife for the last 3 months, and this is causing a lot of frustration for the family. He also reports he's having some new onset headaches that have been going on for about the same time, but he denies any other symptoms. You do a full physical exam and everything appears to be normal, with the exception of the fact that the patient does seem a little bit hard on hearing. You decide to get some basic labs and you find that this patient has normal calcium levels, normal phosphate levels, normal kidney function. However, uniquely, he has an elevated alkaline phosphatase. He has no history of cancer. He has no history of gallstones or cholelithiasis. And so this elevated alkaline phosphatase is most likely due to the musculoskeletal condition of Paget disease of the bone. The reason the question stem is mentioned he has no history of gallbladder disease and could also mention he has no history of liver disease is because you could see elevated ALP in these GI conditions as well. But the key differentiating feature here is that one, these conditions would have different presenting symptoms, right? He might talk about abdominal pain versus his headaches and his new onset of hearing. And two, they would have some other labs that might be increased, such as the gamma glutamate levels. So just a quick summary for this video. We're talking about osteitis deformans, also referred to as Paget disease of the bone. Pathophysiology, really what I want you to know here is that it's an increased activity of osteoblast and osteoclast activity in such that they're not communicating with each other. So we develop poorly formed or woven bone. I think woven as weak bone. This is due to multiple stages, including a lytic phase, mixed phase, sclerotic phase, and ultimately a quiescent phase. This is typically going to present in an older individual, so we wouldn't really expect this to be in a 5-year-old on a question stem. Oftentimes they can be asymptomatic or have fairly benign symptoms, such as the enlarging hat size, hearing impairments, or some mild bone pain. Diagnostics here are going to include getting an x-ray and serum labs. Really important for differentiating with other pathologies is understanding these serum labs. There's not a problem in calcium or PTH or phosphate. The problem is purely in the fact that there's elevated alkaline phosphatase. And again, this has to do with the fact that we have elevated osteoblastic activity. When it comes to the management here, our first line is going to be bisphosphonates, which can interfere with osteoclast survival and hopefully slow down this process that we have going on up here. Complications, really, I want you to know two things are high output cardiac failure. Again, this has to do with the shunt formation and the osteosarcoma as well. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about osteitis fibrosa cystica. Now, osteitis fibrosa cystica is something that can happen, a downstream effect that can happen when a patient has hyperparathyroidism. And if you recall, there's three primary types of hyperparathyroidism. There's primary hyperparathyroidism, where we have direct release of PTH from the parathyroid glands itself. And remember, the role of PTH in the body is to actually increase calcium levels. Then there's secondary hyperparathyroidism, and the most common cause of this is going to be things that cause a low calcium state in the body. Finally, we have tertiary hyperparathyroidism, which is often due to persistent secondary hyperparathyroidism, which is most commonly due to chronic kidney disease. So if we look at our pathophysiology here, we're going to see that the main thing is we have an increased level of PTH leading to increased rank ligand activation, leading to increased activity of osteoclasts and formation of cystic bone spaces / brown fibrous tissue, also known as brown tumors. So let's unpack that a little bit. Remember, parathyroid hormone is imbalanced with calcitonin. Parathyroid hormone is acting to increase calcium levels, while calcitonin is acting to decrease calcium levels. Sometimes people remember calcitonin as it needs to tone it down. You need to tone down the calcium levels. So we're really focusing on PTH or parathyroid hormone here. Now, activation of the rank ligand is going to stimulate the osteoclast. Remember, the C in osteoclast is for consumes. It's going to consume our bone versus our osteoblast, where the B is for builds. So we have overactivation of these osteoclasts. We're consuming more bone. And what happens there is we get these cystic bone spaces and these brown tumors. So if you draw your attention up here to this imaging, you can see kind of these areas where the bone is normal right here. And then you can see this area right here, which is kind of a cystic lesion where osteoclasts have been activated. They've attacked the bone, they've eaten it up, they've destroyed the bone essentially in that particular area, and now it gets replaced with a fatty tissue, and these are known as brown tumors. And they're called brown tumors because when the osteoclasts eat the bone in that area, there's actually some hemorrhaging and some vascularity, as well as some hemosiderin deposit that makes it kind of have this brownish appearance. Now, what are the ways that this can occur? Well, we can have primary hyperparathyroidism, which can often be idiopathic due to parathyroid adenomas or due to malignancy. And so that's where we have increased PTH leading to increased calcium. And we contrast this with secondary hyperparathyroidism, which is most commonly seen in chronic kidney disease or CKD, where we're also having increased PTH because it's called hyperparathyroidism, but it's due to a decreased calcium level. So it's a reactionary response. So I think about primary being the primary organ involved is the parathyroid hormone. So it's direct stimulation, right? The adenoma is going to create more PTH. But a secondary problem, anytime we say something is secondary medicine, it's due to something else. So the primary problem here is the chronic kidney disease. And secondarily, we're getting this hyperparathyroidism, and that's why this is called secondary hyperparathyroidism. Now, if we move on to our presentation here, this is going to classically present with bone pain as well as other signs of hyperparathyroidism. These include things like weakness, constipation, abdominal pain, and psychiatric changes. And bone pain should make sense to us, right? Because if we have stimulation of the osteoclast and we're actually destroying some of these bones, or we're eating them up or consuming them, it makes sense that patients could have bone pain in those areas. They can be predisposed to fractures and other things that can cause problems as well. Now, if a patient has primary hyperparathyroidism, we can also see signs of hyperparathyroidism. These include things like weakness, constipation, abdominal pain, and psychiatric changes. Why in primary hyperparathyroidism? Because in primary hyperparathyroidism, we have the elevated levels of calcium, remember? And so this is going to be our classic bones, stones, groans, and psychiatric overtones. Bones referring to bone pain, stones referring to an increased risk of nephrolithiasis. Why? Because elevated calcium levels predisposes us to calcium kidney stones. Groans is due to the constipation, and the psychiatric overtones are due to the psychiatric changes such as depression that can occur when a patient has elevated levels of calcium. Now, when we think about the diagnostics here, most of our findings are going to be seen on X-ray. We're going to see things like decreased bone mineral density, subperiosteal thinning, cystic lesions, and the salt and pepper skull. So we already showed you up here one of these brown tumors and these cystic lesions, but if you draw your attention down here as well in the hands, you can kind of see these are also brown tumors. These are cystic lesions. Again, that overactivation of the osteoclast to consume some of the bone, these then get replaced with fibrous fatty tissue, creating this brown tumor appearance. Now, if we think about the salt and pepper skull, you can kind of see and appreciate the skull that you see areas of white along with other areas of darkness, right? It's kind of this salt and pepper appearance on the skull. And again, this is a classic finding of osteitis fibrosis cystica. So they might show you this image in a question and expect you to make the correlation that, oh, this patient might have something that causes osteitis fibrosis cystica, such as chronic kidney disease. Now, it's really important that we know the serum labs for any of these things that involve the kidney, the calcium, the PTH. This is one of the most classic questions they will ask you. They will give you a table of all the different arrows. A lot of students will get overwhelmed and confused. A test taking tip I have for this is when you get these kind of questions with a table full of arrows and you're not sure where to start, pick that one that you're most confident with. If you feel very confident that you know which way the PTH goes in primary hyperparathyroidism or even secondary, then start with that and go through the table. Rule out the ones that don't make sense. If you know that you're looking for an up arrow in PTH, well, then start crossing out the answer choices that have a down arrow in PTH. And now you maybe have eliminated 2 of the 5 options right from the get-go. Then you go to the second serum lab value that you feel the most comfortable with. Maybe this is calcium. Maybe you feel you really know the PTH and calcium in differentiating primary versus secondary hyperparathyroidism. Maybe you're less confident in what the phosphate actually does. Well, again, test-taking strategy. Start with what you know the best, go down to what you know the least. Eventually, you can kind of cross out answers. So maybe you want to leave yourself with 2 option choices to choose from. This is a much better statistical way to approach the test. You've gone from potentially a 1 in 5 chance of getting the question correct to a 1 in 2 chance. And if you do this over the course of the exam, it's going to work out in your favor. You're going to get more questions correct if you're able to apply this test-taking strategy appropriately. So yes, ideally, we want to know every direction of every arrow with every lab. But again, test-taking strategy, start with the one you feel the most confident in. Now, when we think about primary hyperparathyroidism here, our serum labs are going to show an elevated PTH, and this should make sense. This is hyperparathyroidism. This is going to lead to an increased calcium. Again, we said the primary problem is at the parathyroid glands itself. So this is classically the parathyroid adenoma. Sometimes it's a malignancy or carcinoma, but it's an increase in either PTH from the parathyroid glands, or it's from a similar molecule, sometimes called PTHRP, or parathyroid-related peptide, when we're dealing with malignancies and carcinoma, that directly increase the PTH level, ultimately leading to increased calcium. So it should make sense. PTH increases, calcium increases as well. Well, you see that our phosphate actually decreases. And why does this make sense? Well, what's our memory aid for PTH? That's right. It's the phosphate trashing hormone. And the phosphate trashing hormone is going to cause more phosphate to be excreted from the body. And so PTH is going to lead to decreased phosphate levels with a healthy kidney. This is important because when we talk about secondary, it's going to be a little bit different in a diseased kidney. We're also going to see an elevated ALP, and the reason is because although PTH primarily is stimulating the osteoclast and having an increased activity to create bone cysts, it's actually also technically increasing osteoblasts as well. Anytime we have osteoblast activity working in the body, we're going to see the elevated levels of ALP. Now, when we turn our attention to secondary hyperparathyroidism, we're going to have elevated PTH as well. Again, this is still a hyperparathyroid problem. However, we are now going to have decreased calcium, and this is super important because look at this contrast we're making here. This is the key differentiating feature on labs between primary versus secondary hyperparathyroidism. Why does calcium decrease? Well, if we have chronic kidney disease, we have other problems or we have other things at play. One is which we cannot activate vitamin D as well. We don't have the kidney function, right? Remember, 1-alpha hydroxylate activates vitamin D, allows us to absorb more calcium. This is problematic. It's not working. Additionally, we said PTH stands for phosphate trashing hormone, and that kidneys would likely offload our phosphate if we increase these levels. But in a diseased kidney, we cannot actually decrease this phosphate level. They're not able to excrete phosphate from the body, and thus we get a buildup of this molecule. And this is really important because a key point that they want you to know is that a negatively charged phosphate is going to bind to a positively charged calcium. And what happens if they bind? Well, we're going to get a decrease in calcium or free calcium in the body. Why? Because it's now bound to the phosphate molecule. We can't use it. If it's bound as calcium phosphate, it's not usable in the body, and it's not measured in the serum lab as calcium. So again, multiple things going on here. Yes, PTH still increases, but PTH is now increased with a diseased kidney, and thus we cannot get rid of our phosphate like we typically would in primary hyperparathyroidism, thus the buildup in phosphate. This leads to decrease in calcium as phosphate and calcium bind to each other, in addition to the fact that the diseased kidney is not able to activate vitamin D, leading to less calcium being absorbed into the body as well. We will also see the elevated ALP for the similar reasons that PTH activates osteoclasts, but it also does activate some osteoblasts as well. Now, when we think about our management here, it's really symptom management. It's going to be vitamin D supplementation or treating the underlying cause, such as a parathyroidectomy for a malignancy or an adenoma. Again, the underlying cause here could be chronic kidney disease. There's a lot of different things. We have a whole video about that, talking about it in detail. There's a lot of things we can do to treat those patients or supplement them. But the idea here is that there's no one cure for osteitis fibrosis cystica. It is a finding that occurs from other conditions. And so you need to treat those other conditions, those primary problems in the patient. So a classic question stem for this type of pathology would include something along the lines of a 6-year-old patient who presents to the primary care provider, and they're complaining of 4 weeks of new onset left hip pain. They're also telling you that they've been constipated for the last 3 weeks despite adequate hydration levels, and they're feeling a little bit depressed. They're not having enjoyment with the activities that once brought them joy. Their sleeping's disrupted, and they're overall just feeling down on themselves for the last several weeks. You decide to get some serum labs, and the labs come back with an elevated PTH, an elevated calcium level, and a creatinine of 1.1. Question then asks you what's the most likely diagnosis, and for this patient, it would be the primary hyperparathyroidism. The reason being because they have several symptoms. They have the bone pain, they have the constipation, and they have the psychiatric changes that have occurred over the last several weeks to months. They also give you a creatinine of 1.1. This is just slightly above what we consider normal, but it's not really in that chronic kidney disease. Additionally, they'd probably give you something like a GFR if they really want to make a point that this patient had chronic kidney disease. In this question stem, they did not. So most likely this patient has primary hyperparathyroidism with some classic findings of osteitis fibrosa cystica, which we talked about here. So just a quick summary to wrap up this video. Osteitis fibrosa cystica is a subsequent finding of parathyroid disorders, right? So we have the elevated PTH. This can be due to primary or secondary hyperparathyroidism most commonly. There is also a tertiary hyperparathyroidism as well, less commonly tested, however. You can have bone pain, and in primary, you can have the stones, bones, groans, and psychiatric overtones. The classic findings of hypercalcemia. On x-ray, we have some pretty classic findings here. The brown tumors are going to be very obvious to us, right? This is very obvious to see that this is different than the rest of the bone. Additionally, you can get the salt and pepper skull, where you see the white kind of interspersed with the darker areas as well. Keep in mind, the labs are super important. The key distinguishing feature here in primary versus secondary is not the PTH. It's what happens to the phosphate and the calcium. And we talked about this extensively, why these values change if the patient has kidney disease. And finally, for management options, remember, there's no one size fits all. There's no one treatment for this. It's really about symptom management and trying to treat the underlying condition, which for patients with an adenoma could include removing with a parathyroidectomy. Welcome back, everybody. David here again with Med School Bootcamp. So in this video, we're just going to do a summary of all the abnormal bone labs that we want to know on test day. Remember, I said a very common question that they like to ask you is to give you a patient presentation of the musculoskeletal disorders and then give you the lab options to choose from. They'll give you a table that looks somewhat like this, where they give you a bunch of up and down arrows, maybe even some signs that indicate no change, and they want you to associate the particular pathology with the serum lab findings. So it's really important we go over those here. The key ones they're going to want you to know are going to be the serum calcium, the serum phosphate, the PTH or parathyroid hormone, and the ALP. So first we're going to talk about osteoporosis. And you should notice right off the bat here that osteoporosis does not have any changes to the serum labs. The labs are going to be normal. And this actually throws students off a lot of times because it's kind of unusual, right? We know in osteoporosis there's an imbalance between the activity of osteoclasts and osteoblasts. We know it typically presents in the elderly population, especially postmenopausal women, as they see a decrease in their estrogen levels. But the serum labs, believe it or not, are actually normal. It's not that they have low calcium or low phosphate or low alkaline phosphatase or PTH, they're actually fairly normal. And the reason this is important is because it's a key differentiating features from a lot of other pathologies. However, there's another one called osteopetrosis, which can actually have fairly similar findings. So you'd see no change in serum calcium or potentially a decrease in serum calcium, no change in phosphate, PTH, or ALP. So now you're probably wondering to yourself, how do I differentiate these two? How do I tell osteopetrosis from osteopetrosis? And really the key way to do this is based on the patient presentation. Remember, in board style questions, they're often going to give you a classic presentation. So if it's a 70-year-old patient who has a vertebral fracture, that's more likely to be osteoporosis. However, if it's a younger patient who's experiencing recurrent fractures, this could potentially be osteopetrosis. There's also a couple unique findings in osteopetrosis that we talk about in more depth in the actual video on it, and these include things like cranial nerve palsies as well as pancytopenia. Remember, we talked about the reason pancytopenia can occur is due to the fact that blood cells are made in the bone marrow, right? So as the bone marrow gets more narrow because of osteopetrosis, where we're getting this thickened, poorly formed bone that increases our risk for fractures, the space becomes a lot smaller. So now kind of sketching in some sclerosis going on around the bone, it's becoming really thick. And you see that the marrow cavity or the inside of the bone, the spongy bone where blood cells are created, is now a lot smaller. So less blood cells can actually be made in there, which leads to pancytopenia in these patients. Now, they might also want you to know that key difference between these two is that osteoporosis is typically an age-related disorder, whereas osteopetrosis is typically a genetic condition. And so that's another key distinguishing feature between osteopetrosis and osteoporosis. Now, moving on to our next one, we have osteomalacia/rickets. Remember, osteomalacia is typically the adult form and rickets is the childhood form. And we're going to see decreased calcium here because this is the primary problem that's going on. Patients are low in calcium for a variety of different reasons. This is most often due to decreased vitamin D levels. We know that vitamin D is super important for its role in absorbing calcium to be used in the body. So patients who might have vitamin D deficiency, those who don't have enough UV exposure, infants who are purely breastfed, or individuals who have malabsorption of fat-soluble vitamins, which include vitamins A, D, E and K, vitamin D being the primary culprit here, can lead to low calcium levels. Now, the key here is that this leads to other downstream effects. Low calcium levels is then going to lead to elevated PTH. Why? Because PTH is the hormone that is activated in the body when calcium levels are low. We sense low calciums, we release PTH to bring more calcium from the bones. This is in contrast to calcitonin, which is a molecule that's actually going to bring more calcium from the serum to the bones itself. Now, if we have elevated PTH, you recall from videos that we've talked about previously, PTH stands for what? Phosphate trashing hormone. So in a healthy kidney, phosphate trashing hormone and elevated levels of PTH is then going to lead to decreased serum phosphate levels. So you can see the primary problem is the decreased serum calcium. This leads to more release of PTH, which then is going to cause less phosphate levels to be present in the body. Now, we'll also see elevated ALP here. However, this is not the most important lab for this condition, as it is for the next pathology that we're going to talk about. And that next pathology is called osteitis deformans, also referred to as Paget disease of the bone. Now, if we look at these labs, we see that serum calcium levels are normal, serum phosphate is normal, PTH is normal, but we get a significantly elevated ALP. And this is really important. This is oftentimes the key differentiating step. If you see normal labs across the board, but they give you that isolated increased ALP, almost always it's going to be Paget disease of the bone in a test question. That's really the pathology that they want you to associate with this serum lab finding. Remember, in this pathology, we have increased activity of rank and rank L, which increases NF-kappa B activation, leading to disorganized osteoclast and osteoblast activity. What ultimately happens is that we get poorly formed or woven bone, which is prone to fractures in these patients. One of the classic ways that this is going to present in a question stem is they're going to give you that history of fractures and things like that you might associate with the bones, but then they're going to mention the patient talking about an increased hat size or some unusual findings, such as some hearing impairments that they're having as well that are kind of new. This is due to the fact that bone is being constantly formed and crowding some of the small spaces in the skull, some of the foramina where our nerves run through, and that's why these patients are having neurological findings and symptoms. Now, when we think about our next pathology, osteitis fibrosis cystica, we have two primary ways that we need to know this. It's for primary hyperparathyroidism and secondary hyperparathyroidism. So I think it can make sense to us that these are both going to have elevated PTH. Why? Because they're called hyperparathyroidism. But the reason they occur or why they occur varies. Now, in primary hyperparathyroidism, we're going to have elevated calcium levels because the primary cause is elevation or increased secretion of the parathyroid molecule from the parathyroid glands. This is commonly due to a parathyroid adenoma that's just constantly secreting PTH, constantly causing calcium to be released from the bone, leading to the elevated calcium levels. We're also going to see a decrease in phosphate because in these patients who have healthy kidneys, this increased PTH, or phosphate trashing hormone, is going to then lead to the phosphate being trashed or removed from the kidney itself, which is why we have a decreased level. Now, super important to contrast this with secondary hyperparathyroidism, which is often due to CKD. And this is an important distinguishing feature because we still have high parathyroid levels, which are going to lead to low calcium. And we say, why? That's different than our primary hyperparathyroidism. Well, the key here is in CKD, the kidneys are not working appropriately. And so we're not able to activate vitamin D to reabsorb calcium. We're not activating with the 1-alpha hydroxylase enzyme we typically would use. So that's one reason calcium is actually lower in this condition. Another thing that we see in this condition is elevated phosphorus. And you might say to yourself, wait a second, you just said PTH stands for phosphate trashing hormone. Well, PTH is elevated. Yes, in a healthy kidney, we can excrete phosphorus from the body, right? We can drop the levels like we see in primary hyperparathyroidism. But in secondary hyperparathyroidism, where we're actually having kidney failure as one of the most common reasons for this to occur, kidneys can't excrete the phosphorus. Even though we're releasing PTH, you still can't excrete it, and it's going to build up in the body. And so now we have a second thing going on. One, calcium is not being absorbed as much because vitamin D is not being activated due to the unhealthy kidneys. And two, this negatively charged phosphate, which is now building up in the body because we can't excrete it, we have the CKD, is going to bind to the positively charged calcium molecule. And so that's going to decrease our serum calcium. The calcium that we can use is active in the body, and it's going to be read as low serum calcium. So it's a double whammy here. We have the binding to the phosphorus plus the decreased activity of vitamin D in the body are going to lead patients with CKD to have the low calcium levels in the secondary hyperparathyroidism. Now, in these patients, you will also see an elevated ALP, less specific finding. ALP is an enzyme that is associated with osteoblast activity, but really the key one that I want you to know the increased ALP for is going to be the Paget disease of the bone, again, because all labs are normal except for that isolated finding. It's very unique. It should really stand out to us on testing. Now, the final one we're going to talk about here is hypervitaminosis D, and this is going to present with increased serum calcium level because we know that vitamin D plays a role in our reabsorption of calcium from the body. So it makes sense that hypervitaminosis or hypervitamin D excessive levels can bring back more calcium. We're going to see elevated levels of phosphorus as well because this can also act to bring back more phosphate into the body. We're typically going to see a decrease in PTH and no change in ALP. And why is that? Well, patients who have hypervitaminosis D, typically from over-supplementation or from a granulomatous disease such as sarcoidosis, are already having excessive amounts of calcium in the body. And remember, PTH is used when calcium is low and we want to release it from the bone. If calcium is really high, then there's not as much need for PTH to be released. We might be releasing the opposite hormone, which is calcitonin, and that's why PTH decreases in hypervitaminosis. So again, this is just a quick summary video for you guys to really understand these lab abnormalities. There's so many different ways they can ask presentations for patients, but I want you to be familiar with this type of question stem. So they give you a patient presentation. They say something about a 55-year-old patient presents to the primary care clinic saying that he's not able to hear his wife quite as well as he used to. He also reports that he plays tennis and some of his sweatbands are feeling a little bit tighter around his head over the last several months. Several months ago, he had a leg fracture, which occurred when falling while playing tennis, and you decide to get some serum labs, which come back completely normal with the exception of the elevated ALP. Well, this question is obviously trying to get you to pick the answer of Paget disease of the bone or osteitis deformans with the patient's history, the cranial nerve changes of hearing, the bone being poorly formed, predisposing him to fractures, and the increase in hat size with his sweatband not fitting quite as well. Also, the isolated ALP is a classic finding for this. So again, you can kind of go through all of these and think about what are the classic questions and what are the classic ways they might ask me about these labs on test day. And if you're comfortable with these, I think it's super, super important because you can really get these questions right every single time. If you feel comfortable with this table, what's going on, and particularly when it comes to hyperparathyroidism, why it's going on. What's the process here? Why is it that calcium increases versus calcium decreases and how it relates to the kidney function? So I think this is super high yield for you. A quick little overview after you finish this chapter, and I wish you the best of luck on test day.